Hi, everyone. There's a lot of information that's being discussed today, and we want to be respectful of everyone's time, so we're going to go ahead and get started. I'm Dr. Robert McKenna with the Office of Regional Operations of the Health Resources and Services Administration, and it's my privilege to welcome you to today's webinar on opioid prescribing, so welcome. And I'm thrilled to have seen so many HRSA and HHS grantees and stakeholders registered. Certainly, you know that the opioid epidemic remains an extremely high priority issue for HRSA and the rest of the United States Department of Health and Human Services. And we're truly thankful for what you do every day, as well as that you've made a point to be here today and participate in this webinar, which we're fortunate to have offered by the American Society of Addiction Medicine, or ASAM, and the SAMHSA-funded Central East Addiction Technology Transfer Center, or ATTC. ASAM and ATTC partners know that we're tremendously grateful for the opportunity today and for your ongoing collaboration in helping to address the opioid epidemic through activities like today's. And with that said, would you please tell us a little more about what you want everyone to know about your programs and more about today's webinar?
Thank you, Rob. This is Jack Williams from the American Society for Addiction Medicine. I will be moderating a large portion of the webinar, including, so if you submit questions through the GoToWebinar panel, I'll be able to see them and answer questions throughout the webinar. Additionally, if you have any questions for Dr. Salsitz, you are able to submit questions during the webinar or at the end when we begin our Q&A session. Additionally, throughout the webinar, there will be individual points with polling questions. Some of them you'll be able to answer multiple choice and just answer one answer. The other ones, you'll be able to answer multiple choices, and it will clarify that. You'll be able to just click on it in real time when you see it. Without further ado, I'd like to introduce Tamara Parris from the ATTC.
Thank you, Dr. McKenna, and thank you, Jack Williams. As I said, I'm Tamara Parris, and I'm with the Central East Addiction Technology Transfer Center funded by SAMHSA. We are comprised of 10 regional centers and a coordinating office. Central East is excited to partner with HRSA's Region 3 office and ASAM. Our goal is to strengthen the behavioral health workforce and allied health care workforce that provides substance use disorder treatment and recovery services through training, technical assistance, and resources. I encourage you all to visit our national website to locate your regional center. I'd like to review now some details pertaining to the continuing education. These details can be found in the About Continuing Education document in the handout section of the webinar control panel. Continuing education is sponsored by ASAM for physicians, physician assistants, and nurses. Continuing education for certified health education specialists, addiction specialists, and social workers is sponsored by the ATTCs through the Dania Institute and the University of Missouri, Kansas City. A note to social workers, credits are only available for a maximum of 2.5 hours. All certificates will be sent within 4 to 6 weeks of your request. Upon completion of today's webinar, you will receive an email with instructions for completing CME requests and other continuing education requests. A quick reminder, CEUs are only available for live visual and audio presentation, not for telephone-only participation. So if you're planning to seek continuing education, you'll need to please sign in online so that we can have a record of your live attendance. For participants viewing and listening as a group that are requesting continuing education other than CMEs, please be sure that your group leader goes to the handout section in the control panel of the webinar to download the group participant sign-in document. All live participants need to be recorded either by logging in or via this sign-in sheet, especially if you want a certificate of attendance or continuing education credit. Again, these are not for CMEs. With that said, it is my privilege to welcome you to today's presenter, Dr. Edwin Salsitz. Dr. Salsitz has been an attending physician in the Beth Israel Medical Center, a division of the chemical dependency since 1983, and is an assistant professor of the medicine at the Albert Einstein College of Medicine. I have personally worked with Dr. Soltitz when he gave a highly rated presentation on medication-assisted recovery at our previous ATTC conference on HIV and substance use disorder in Baltimore and other states. I encourage you to take a look at his brief bio showing on the webinar flyer document if you already haven't. And you'll agree that we are very lucky to have him sharing some of his expert knowledge with us today. So without further delay, please join me in thanking Dr. Soltitz in advance. Dr. Soltitz?
Thank you so much, Tamara, for that overly generous welcome. I really appreciate it. And hello to everyone on the webinar. Thanks for joining and taking the time and having the interest to participate in the webinar. So the title of the webinar is called Opioid Prescribing, Safe Practice Changing Lives. And we're going to focus in on safe prescribing of opioids, effective prescribing, some of the rules that go along with it. But I also want to broaden it out a little bit and give you more of a perspective on what's actually going on with this opioid epidemic in the United States these days. So again, here's a formal welcome with a slide. Here's my brief bio. So let me just summarize my bio as saying that I'm an addiction medicine specialist. I trained as an internist. I did pulmonary diseases for a while, but now I just do addiction medicine, and I'm here representing the American Society of Addiction Medicine. There are a number of organizations involved in these courses, which are called REMS courses, Risk Evaluation Mitigation Strategy for Opioids. The word CORE stands for Collaboration for REMS Education. And you can see that there are many organizations involved, and today we're under the aegis of the American Society of Addiction Medicine. These are pictures of some of the faculty who make up the slides and make up the content. And it should be noted that we have a diverse faculty. We have MD, DOs, we also have PAs and NPs on the faculty. Together we meet from time to time, try to update the slides and develop content that we think is current and appropriate. Again, American Society of Addiction Medicine. If you do any sort of work in addiction, this is a wonderful society, a wonderful website on the American Society of Addiction Medicine. Lots of good resources. So you might want to check out the website, asam.org. These courses are given in many places across the country, and funding for the logistics of giving the courses is provided by the pharmaceutical companies which make the opioid analgesic products. They have no impact on the faculty, on content, on direction of the course. They just have to, by FDA regulations, supply funding so that the courses can be given across the country. We're going to talk a lot about opioids today, and this is just a very introductory slide, nothing that you should get too concerned about. But on this side of the slide are the names of most of the branded opioid products. And what's really interesting is that I've been doing this talk for about 5 years, and a number of years ago, the slide ended about over here in terms of branded products, and yet products keep being approved even though we're in the midst of this opioid epidemic, and that's something that people don't quite understand, how more and more products get approved. On this side of the slide are generic opioid products. This is an incomplete list. For example, hydrocodone is not on this list, and other hydromorphone, other products that are generic are not listed here. So this is just a very introductory slide saying there are a lot of opioid prescription analgesics, both branded and unbranded, that are available to be prescribed. Why are we here? Well, we're here because people are using way too many pills, not only opioids, but benzodiazepines, stimulants, maybe even muscle relaxants, and we're trying to figure out how we can do this appropriately. So since most of our talk today will in one way or another involve opioids, I thought I would start right at the beginning. And right at the beginning is the opium poppy plant called Papaver somniferum, opium poppy plant. This is probably growing someplace in Afghanistan, which is where most of the opium poppy is grown and where most of the heroin is coming from. Many of you have a different variety of poppy plants in your gardens, not the opium poppy, but other varieties. They have beautiful flowers. They're hardy plants. They perennials. They usually bloom in the springtime. Red flowers, orange flowers, white flowers. When the flowers fall off the plant, you're left with what's called the unripened seed pod. If you cut into that seed pod with a razor blade, you get this milky, grayish, brown fluid that comes out. This is raw opium, and raw opium has been used for millennia for a variety of medical indications, and some people use raw opium today. Some people smoke raw opium. Raw opium has a number of very important chemicals in it. Most important is morphine. About 10% of raw opium is made up of morphine. Codeine is also in the raw opium, and a number of other plant alkaloids. If you do not cut into the seed pod and you let it ripen, which takes a month or two, and then you shake out the seeds, you get poppy seeds. When you eat a bagel or a cake or something else that has poppy seeds in it, the poppy seeds are actually coming from the opium poppy plants. And that is why it is possible, depending on the sensitivity of the drug test that's being done, to test positive for morphine or codeine if you do eat a poppy seed bagel that has a high morphine or codeine content. So this is the molecular structure of morphine. When two acetyl groups are put on morphine, it gets converted to heroin. So heroin is actually a semi-synthetic opioid converted from morphine. Why do people like heroin more than morphine? It is more lipid soluble, so it gets into the brain a little bit faster than morphine. However, it is rapidly converted back to morphine in the body. So you never ever find heroin on a drug test. You might find an intermediate product called 6-monoacetylmorphine if you're lucky, but that only lasts for 30 to 60 minutes. When people use heroin, the drug test is going to show morphine or opiates. Heroin is actually a branded product from the Bayer Pharmaceutical Company, the same company that developed aspirin. And they developed heroin because people in the late 1800s were having trouble with the morphine that they were getting from whatever you wanted to call pharmacies back then. They were misusing it, abusing it, and so the Bayer Pharmaceuticals Company said, you know, we have the answer to this problem. The answer is going to be heroin. It's going to cure the morphine problem, which of course it did not. Providers of all kinds have this dilemma where pain is a very, very common complaint, usually listed as the most common reasons that people see primary care providers. So we want to provide pain relief. On the other hand, particularly with opioids and other medications, we want to avoid some of the negative problems that can occur, like addiction or misuse of these pharmaceutical products. And we're stuck with trying to strike the right balance, getting benefits with very little in the way of risks and other negative outcomes. A number of years ago, the Institute of Medicine published this landmark report, which is often quoted, and they said that over a third of Americans have chronic pain. It's a very expensive proposition for our country, our healthcare system. And it was noted back then that some physicians overprescribe opioids, others refuse to prescribe, and there was a general agreement that there was really a lack of education about opioids, both on the side of the providers and also patients. There were many myths, there were many misconceptions, and that more education was needed. And so we went through a period of time where more and more opiates were being prescribed, particularly for chronic non-cancer pain. And here's an interesting graph showing 30 different nations and how much opioids they consume. This is prescription opioids, you know, by legal prescription. And here's the United States up here at 50,000 daily doses per million inhabitants. And you can see that we're an outlier compared to other countries. These countries are, you know, advanced, developed Western countries that have very good healthcare systems, and yet they're using often less than half of the total amount of opioids that we're using per capita. The flip side of this slide, and it's not really shown here, is that there are places, particularly in Africa, some places in Asia, where there either is no opioid available or very minimal opioids. There was a recent article in the New York Times focusing on Nigeria, and they showed people with terminal cancer, very painful problems, and they just had to live with that pain because they just could not obtain opioids. So yes, we're using too much in the way of opioids, but there are other places where the flip side is true, where there are insufficient amounts of opioids, and there are there's lots of prejudice against using an opioid, which there should not be, particularly for cancer end-of-life care. So we've been through a remarkable number of years, maybe 15 years. This is looking at 1999 to 2009, only a 10-year period of time. The top line is the sales of opioid analgesics, and they quadrupled somehow in 10 years. So did opioid overdose deaths from opioid analgesics, and so did admissions to treatment centers to treat opioid use disorder. You can see that all three lines kind of go up in a parallel fashion, and almost all of them have quadrupled in 10 years, which seems unusual. Here's another graph showing the prescription opioid overdose death line from 1999 to 2010. Take a look at the heroin line in green. It stayed relatively stable, relatively low. It started to inch up around here in 2007. This graph only goes to 2010. You'll see what happens on the next graph, which is pretty remarkable. We're going to mention benzodiazepines just a few times. They're really important. They contribute to a lot of the overdose deaths. Nobody has a good answer to what to do about benzos. They're a very vexing problem, both prescribed benzos and illegally obtained benzos. A huge problem, but we're not going to spend much time talking about it. And one of the reasons is there's not much information available as to what's the best answer to the problem. So you remember on the previous graph in 2010, that's where it stopped, was staying relatively stable with a little bit of an increase here. And then look at this in the last, from 2010 to 2014, the steep increase. These are now overdose deaths and heroin-related deaths. Prescription opioid prescribing has gone down since 2010. Death rates are coming down, but they're still not down enough. But the real problem now is heroin, and the next slide kind of puts this all together. So this is 2000 to 2015. These are all opioids: heroin, fentanyl, prescription opioids. And that's been termed the opioid epidemic by the CDC. But actually, this epidemic consists of three sub-epidemics. The first one was what we've been talking about, the prescription opioid problem, with the quadrupling of deaths and prescriptions. The second one is heroin, which I showed you started to really go up in 2010 and is still currently a very big problem. And the last part of this epidemic, the most serious, is the fentanyl problem. And that really is the problem right now. Fentanyl either replacing all of heroin or contaminating much of the heroin across the country, leading to very significant overdose deaths. So in 2016, the latest year that data is available, the CDC is saying that about 64,000 people died from drug overdoses, and these are primarily opioid or opioid and benzo overdoses. And you can see that when we look at other epidemics that we've had, for example, people who die in car crashes, the peak occurred in 1972, and it was lower than what we have now with opioid overdoses. This is peak HIV deaths in 1995, again, lower, and peak gun deaths, also lower. So when we think about all of these serious problems in the United States causing death, now the drug overdose is number one and is considered the number one cause of preventable accidental death in the United States. And here's just one more graph of the fentanyl line going so steeply up. I think in 2016, people thought that 20,000 of the 60,000 deaths were caused by fentanyl. The heroin line is going way up. And looking to the future, because one of these days the opioid problem will come under control, but looking to the future, it looks like cocaine and methamphetamine are starting to go up, and that imports from Colombia of cocaine are starting to go up. So another way to look at this, this is heroin. These are the lethal doses of the drugs. This is the amount of heroin. I guess it would depend on the purity of the heroin, but in any case, this is the amount that would be considered lethal. Look at the difference in terms of fentanyl, how much would be considered lethal. And here's carfentanil, which we'll talk about in a moment, where 1 or 2 grains are fatal. This is often called the elephant tranquilizer. I don't know if I have a slide on this, so I'll go back here for a moment. Heroin is twice as potent as morphine. Fentanyl is 100 times as potent as morphine, and carfentanil is 10,000 times more potent than morphine. Really incredible numbers, and this is what people are getting when they're buying illegal drugs these days. Not only when they're buying heroin, but unfortunately when they're buying other drugs as well. They may get that. This is Dayton, Ohio. Ohio has been very hard hit by the opioid epidemic. Different states have been hit harder than other states. This is looking at overdose deaths in the first 3 months of 2017, 100 accidental overdose deaths in the county around Dayton, Ohio. 99% of the postmortem toxicology showed fentanyl. Only 3 cases were positive for heroin. Something that I did not know until relatively recently was that fentanyl can kill people in 2 different ways. One way is the usual respiratory opioid overdose way, where your breathing rate goes down, your oxygen goes down, and unless it's reversed, you die. But that takes time, maybe 15, 20 minutes, something like that. But the other way that fentanyl kills people is that if people take it IV, particularly rapid IV administration, the muscles that breathe, the chest wall muscles, go into spasm. It's called rigid chest wall or wooden chest, and they just can't breathe. They can't take a breath. And this is going to kill people in a couple of minutes. And in this slide, what's shown here is that 99% had fentanyl, but only 2/3 had the metabolite of fentanyl, which appears within 2 minutes or 3 minutes of using fentanyl, but they had no time to make the metabolite because they died so quickly. And this is an issue in terms of how well will naloxone work and how can first responders manage this. And probably they can't right now because the death is occurring too quickly. So these slides that have the core logo here are the formal slides, which I'm supposed to be using, but I like adding in my other slides to give you more of a global picture as to what is going on. But here's a summary from the core slides about the fentanyl. We talked about the dramatic increase in overdoses with fentanyl, and really this is the problem right now. The fentanyl that people are buying does not come from pharmaceutical fentanyl, such as the fentanyl patches. All this fentanyl is being synthesized by chemists in China and then being imported into the United States. And you can see that from a drug dealer's point of view, it's much easier to be selling fentanyl, which you just synthesize in a lab, whereas with the heroin, you have to harvest the raw opium, you have to get it to a laboratory, you have to convert it from morphine to heroin. It's a much bigger bulk, you have to bring it into the country. So fentanyl is much easier from a business point of view. I discussed the 2 causes of death, the respiratory and the chest wall syndrome. Now this is the other terrible problem, and that is that people are buying cocaine, and that's been contaminated with fentanyl. People are buying pills that they think are Xanax, that are fentanyl, Percocet, they think are fentanyl. And so you get these outbreaks of overdose deaths in different counties in the country when something like that occurs, because people using cocaine have no opioid tolerance. And if they're all of a sudden hit with fentanyl, it's going to be very hard for them not to overdose and die. So we have in these courses what we call state-specific slides. And for today's audience, we have 5 states and the District of Columbia. And from time to time, depending on which topic we're talking about, you'll see me run through the 6 specific slides. This also gives me a big geography lesson. I have to learn that that's the District of Columbia. So here you have a map of the United States. The darker the color of a state, the more opioids are being prescribed in that state. So one thing you can see in the United States is that there's a lot of variability in how much opioids are being prescribed by state. And what's interesting is even when you have these adjoining states like Texas and Oklahoma, for some reason you have considerably more opioids prescribed in Oklahoma than you do in Texas. And I think I'll show you a slide later that goes back to this. But anyway, for the District of Columbia in 2015, they're saying you had 125 overdose deaths, and your prescribing was in this category, which is not that high compared to other places. This is Delaware. You had 198 deaths in 2015, and you are in the same, you have a little bit more prescribing than Washington, D.C. This is Maryland, and you have, what do you have in Maryland? You have back here a little bit less prescribing, that number of deaths. Pennsylvania, you have this level of prescribing, second from the highest. You've had over 3,000 deaths in 2015, and now we have Virginia, and Virginia has a lower level of prescribing and this level of deaths in that period of time. West Virginia, I've been to West Virginia a number of times in Morgantown. All of Appalachia, Kentucky, West Virginia, Tennessee, parts of Ohio, Indiana have been particularly hard hit by the opioid epidemic. West Virginia is #1 in the country in terms of deaths and problems, and you can see that they have the highest rate of opioid prescribing. So here are all 50 states listed from the top to the bottom in terms of overdose death rates. And as I said before, unfortunately, West Virginia is #1 on the list. If you want to read a great article about what's happening in West Virginia, there was an article in the New Yorker magazine a number of months ago about, I think I'm going to say the city correctly, Martinsburg, West Virginia, and what's going on there with opioid overdoses between the first responders, whole families being decimated. You might want to try to get that article in the New Yorker. It's really an overwhelmingly sad article. So there's West Virginia. Here's Pennsylvania. Further down on the list, Delaware. Further down, Maryland and Delaware are about the same. District of Columbia down here. And Virginia is the lowest of the 6 localities we're discussing today. Areas of the Midwest, like the North, South Dakota, Nebraska, are very low. And up here again, Appalachia is the highest among the 50 states. I like this graph of the United States. The darker the color of the state, the more deaths they've had from opioid overdoses. The circles, the yellow circles, represent the amount of prescription opioids being prescribed in the state. And you can see that in general, with some exceptions, the more opioids being prescribed in the state, the darker the color is, the more deaths that they have. So you can see in a place like New York, we don't have that much prescribing and we don't have that much deaths. Same thing in Virginia here. Pennsylvania has more deaths. So there is a correlation between the amount of opioids that have been prescribed. This data is a little bit old now, ended in 2010. Things have changed a great deal, but there has always been a correlation between the amount prescribed and the number of deaths in a state from that. This is another piece of remarkable information, that 12 states have more opioid prescriptions than people, and we have Alabama, Tennessee, West Virginia, again, Appalachia, always #1. None of our 6 locales today are on that list. So back now to the core standard slides, the pendulum swings. So for many, many years, we had underprescribing, we think, of opioids. It was called opioid phobia. People were very reluctant to prescribe opioids. They thought that could cause a lot of problems and it shouldn't be done. And what that led to was unresolved pain. And back then means like the 70s, the early part of the 80s, there were providers who were sued by patients who claimed that the provider ignored their pain, didn't address it, didn't deal with it, and the providers lost the cases in court. They were sued and they lost the case that they hadn't adequately taken care of the pain. So then we went from that to overprescribing. And that started in the late 80s, but it really revved up in the 90s and the 2000s. And what did that lead to? That has led to everything we've just talked about, the overdoses, the addiction, and we'll talk about it in more detail as we go along. And so what we're trying to accomplish with this course and other activities is to have appropriate prescribing, and we hope that that's going to lead to adequate analgesia and better functioning of patients. So this pendulum, by the way, the maker of the slide, the animation, we asked them to stop the swinging, after like 3 or 4, but apparently can't be done, so this thing's going to keep going. What do we want from opioid analgesics? Well, we want some sort of pain control. We don't want the pain to go to 0 because that doesn't happen in chronic pain, but we want some adequate pain control with the ERLA standing for extended release long acting. So I want to be able to use that acronym ERLA, extended release long acting, as opposed to immediate release or IR opioids. But this is the main thing we're looking for with pain treatment in 2017, and that is improved function. We want people getting off the couch, back to work, back to school, putting a life together, which would go with the quality of life. The risks of opioids particularly, and other medications used for pain as well. I know you all know this, but we'll just run through some of them. The most serious risk is an overdose with respiratory depression, but also this has been a big problem over the last 15 years. Misuse by people in the household who get a hold of the opioids, people becoming addicted, physical dependence and tolerance so that people, when they want to taper off, have trouble tapering off. Some of these opioids interact with other medications or other CNS depressants like alcohol and benzos. Many more women now are giving birth to babies who have been on opioids during the pregnancy for a variety of reasons. This has led to a significant rise in neonatal abstinence syndrome. And also children, occasionally pets like dogs and cats, have rolled over onto an unused, a used fentanyl patch and become an overdose, and even overdosed and died. So all of these issues are very important in terms of the risks. Now, when people illicitly use prescription opioids, where do they come from? Well, it's often said that the vast majority comes from either by buying it or getting it free from a friend or relative. In the other big chunk here is that they have a prescription and they fill a prescription, or they somehow or other steal it from somebody who has a prescription. I think the point of the slide is to say that very little of these prescription opioids came from the internet or from foreign countries, etc. They mostly came from inappropriate prescribing and people sharing them. Now, in terms of sharing your opioids, which is the red bar, that can work as long as you're not using the opioids regularly. But once you start using them, let's say 100 times, 100 days out of a year or more, or every day, you really can't get them much from the friend or relative. They're not going to have enough. You've got to find somebody to prescribe it, or you've got to use some sort of illegal means to be able to obtain that kind of quantity. Now, another place where opioids come from is from unused opioids. This has become a very significant topic in the last few years. So this is a study looking at people who had a variety of different surgical procedures: orthopedic, urologic, thoracic, dental, cesarean section, general surgery. And when you go home from the hospital and you've had surgery, most people get a prescription for opioids. They generally get more than they need, and in this study, 70 to 80% of the opioids which were prescribed when people went home from the hospital were unused by the patient. They didn't need them. And so these opioids are hanging around the home, and people are getting a hold of them, particularly if there were younger people, adolescents in the home. And so one of the messages is, don't overprescribe the opioids. Now, just a personal matter for myself, I had a hip replacement 2 years ago. I took 1 oxycodone on day 1 of the hip surgery because I was doing some physical therapy. The nurse said you should do it. I was kind of reluctant. I didn't really have that much pain, but I took it. I got dizzy. I got nauseous. I didn't get much pain relief. I never took another one in the hospital. I left after 48 hours. And they had a prescription ready for me for 100 Percocets to take to the drugstore. I filled it because everyone said to me, that the physical therapy I'd be doing at home for the next 2 weeks was going to be very, very painful. It wasn't. I never took any of them, and I eventually threw them out. But this is happening when people go to a dentist, let's say for a dental extraction. They're leaving with a bottle of 30 Percocets when they don't need either any or very few. And we'll circle back around to this issue of how much should be prescribed. But this I found to be a very effective analgesic, and that is sitting on the cooling pad. And we'll see when we get to the CDC guidelines for how to treat chronic pain that the first recommendation is going to be use non-pharmacologic modalities like a cooling blanket and other modalities, which we'll talk about. So these core courses, this core education, many agencies are involved and make suggestions, but it's primarily the FDA which gives us a blueprint and says, these are the topics we'd like covered. Please develop the appropriate content, and then they have to approve it. And we're supposed to show most of the slides that have been approved through this FDA process. This has been going on for about 5 years. Again, it's called Risk Evaluation Mitigation Strategy. There are other REMS courses for things like, I think, Accutane, one of the acne medications, some of the more potent psychiatric medications, where the FDA thinks that extra training by providers is required for appropriate prescribing. So here's our basic statement, and that is that misuse, abuse, diversion, and overdose of opioids has created a serious public health problem in the United States. We just went through the slides and the graphs that validate that. When prescribed well and used as prescribed, opioids can be valuable tools to effectively treat pain. I'm going to show you at the end, when we come to the end of this slide set, that there could be a question mark over here in terms of how effective are chronic opioids for chronic non-cancer pain, particularly, not for other forms of pain, but chronic non-cancer pain. And we want to emphasize that this course does not advocate for or against the use of immediate or extended release opioids. Our purpose is to provide proper education about safe prescribing practices along with effective patient education. We have a bunch of learning objectives, which I don't want to go through because I know eventually time is going to be a factor, and you're going to have access to all of these slides, and you can look at this, but we're going to cover a whole variety of topics related to appropriate prescribing. Here's a little motivation. You and your team can have an immediate and positive impact on this crisis while also caring for your patients appropriately. So we're talking about pain today, neuropsychobiology of pain. So here is an illustration of a peripheral injury. Somebody steps on something sharp with their right foot. They're injured, and the nerve fibers in that part of the foot pick up the fact that something has happened that is causing pain, and that pain is transmitted from the foot via a variety of pain fibers into the spinal cord where it crosses over, and then the pain signal goes up into the brain. Now, it's very, very important for humans to be able to have high pain sensitivity so they can tell when something painful has occurred, because when anything painful occurs to an animal, it can be a sign of grave danger. And so evolutionary-wise, people are sensitive to pain, and they should be, and then they have to try to figure out, what does the pain mean? And that's what these tracks are about. The pain goes into the spinal column, crosses over, goes up into the brain, and when it gets into the brain, it goes to different parts of the brain. It goes to a part of the brain called the somatosensory cortex, and it's in that part of the brain where the body is told, the brain is told, that this injury was in the right foot, it was caused by a sharp object, it's not the end of the world, you're going to have to take care of it, but your life is not threatened by this injury, as opposed to being scratched by a tiger in the jungle. That would be a different kind of painful reaction that you would have. So the other places where the pain signal goes, I want to call it the limbic system part of the brain, which deals with feelings and emotions, or the affective response to the pain. In other words, what does this pain mean to me? Am I somebody who has survived breast cancer, and now I feel I have a pain in my back, and I'm worried that this pain can be a metastatic lesion from a recurrence? Now, that's going to be a different assessment in your brain than stepping on a sharp object with your foot, knowing that this is a relatively trivial problem. And this interpretation of what does the pain mean has become a very, very important topic in trying to understand why some people develop chronic pain and why some people's chronic pain is so much more difficult to treat and manage than other people. Looking at the brain in this way, a sagittal section of the brain, and talking a little bit about the addiction issue, when people take an opioid systemically, like by mouth, it goes to every place in the body, and Mother Nature has mu opioid receptors, widely scattered in the brain and other parts of the body, and these opioids, whether they're opioid analgesics or heroin or fentanyl, they attach to mu receptors, and depending on where the mu receptors are in the brain, they subserve different functions. So, when somebody takes an oxycodone pill, we hope that it attaches to mu receptors in the periaqueductal gray area and analgesic center in the brain, and that by attaching to the opioid receptor in here, it provides pain relief by inhibiting the signal from going further upward and by enhancing the descending pain pathways. But the oxycodone is also going to go into the limbic system. This is the part of the brain most affected by addictive diseases. And in this part of the brain, it's not going to be pain relief, it's going to be euphoria or pleasantness that is produced by the opioid. And some people who are vulnerable to becoming addicted to opioids, when they take their first few pills of oxycodone, let's say from a dentist, will recognize that in addition to the pain relief, they're also getting something else. They're getting a relief of anxiety, depression, shyness. They're forgetting about the abuse that has occurred to them. And that's how the vulnerability to opioid addiction begins, by the feeling that I like these opioids and also that they energize me. Now, that was a very, very brief overall view about the addiction potential of these opioids and why they are potentially addictive. Understanding pain. So the main point of this slide, and you can see that the slide's going to get filled in with way too much text in a moment, is that pain is more than just the physical pain, whether it's nociceptive pain like that peripheral tissue injury or neuropathic pain like diabetic neuropathy or post-herpetic neuropathy. Pain is more than the physical pain. It has a biopsychosocial context made up of what does it mean physically, psychologically, spiritually, socially, and putting all of that together gives you the final experience of pain. And here's some more text in case you thought the slide didn't have enough. To say, and the point of this slide is just to say that pain is very multi-dimensional. It isn't only one thing, and it's very, very different for each individual, how they experience it and what it means to them. So the impact of pain, and we could also have addiction sitting here in this box. It's more than just the pain. It starts to affect other areas, and there are these comorbidities, particularly psychiatric comorbidity. It's psychiatric comorbidity is at least 50% in people with chronic pain. Sleep disturbances are common, stress, etc. And if you're taking care of anybody with a chronic pain syndrome like fibromyalgia, I'm sure that all of these different comorbidities will be recognizable to you as common and prevalent in that patient population. So, we're looking for a multimodal approach to a multi-dimensional problem. And so these other ways of treating pain besides pharmacotherapy, particularly opioids, has also become an increasingly important topic with more and more evidence to back up the interventions. So cognitive behavioral therapy and other forms of psychotherapy or psychosocial interventions have evidence to help people deal with their pain, help people not catastrophize the pain, and develop more self-efficacy about dealing with the pain. Because in most cases of chronic pain, the pain score will not go to 0. There will have to be an adaptation made to deal with the pain. So that's one box. The other box, I think this is the most popular right now, are physical modalities. So physical therapy has a lot of good evidence, exercise, acupuncture has evidence, different forms of movement therapies, mindfulness, hot and cold treatments. I mentioned how helpful I found the cold treatment after my surgery. If we were in a live course, I know that the question would be asked, yeah, I've read that this is great stuff and it really works, but it's very hard to access. Insurance often doesn't cover it. There aren't that many providers. How do I actually make this work? There's no good answer to that, except that increasingly, with more and more guidelines recommending this as the first step in treatment, hopefully some of the insurance payers will change their approach and cover it, and it'll become more accessible. But no one's got a good answer to that question that's always asked about access. Now, there are also interventional treatments, and there are some pain specialists who do only intervention, and there's a mixed literature on many of these interventions. For example, do epidural injections work for chronic back pain? They seem too short-term. How durable the effect is debatable. How often they should be given is debatable. Nerve blocks work for some people. What I'm seeing more data on are these spinal cord stimulators. Newer ones are coming out. They seem to be more effective for back pain, leg pain, radicular pain from disc injury, etc. So I think stimulators are coming along. And then we come to the pharmacotherapy, which again, very important. We're never not going to need pharmacotherapy. But let's run through this just very briefly now. NSAIDs. So NSAIDs are very commonly used, but there's a mixed literature on how effective they are. In some studies, let's say for knee osteoarthritis or hip osteoarthritis, they come out no better than a placebo. If you look at the warnings on NSAIDs, they're very severe. NSAIDs are not a walk in the park, a picnic in the park. There are cardiac warnings. Even with the first dose, the FDA says you can have an MI. There are renal problems. There are gastric problems. And many of the people who might want to take NSAIDs already are compromised in some of these areas of their body. So a lot of people take them. Some people find them effective, but they come with significant adverse effects. Antidepressants. These are primarily the SNRIs like duloxetine and venlafaxine. Now, these were developed because the recognition was that people with depression, at least 50% of them have chronic pain and vice versa. And a molecule like duloxetine was supposed to treat both both depression and pain. Let's leave opioids go for now. Let's leave cannabinoids go because we have slides on them coming up. Anticonvulsants, particularly the gabapentinoids, gabapentin, pregabalin. So I know that I try to use them in order to avoid prescribing opioids and benzos. So I'm using them for insomnia. This is all off-label use, by the way. Insomnia, anxiety, and sometimes they work and sometimes they don't. But the problem that we're facing now is that there is a lot of misuse and diversion of the gabapentinoids. And there are a couple of articles which recently came out showing that if you're on an opioid and a gabapentinoid, which is a very common combination, overdose risk is higher than if you're only on an opioid without the gabapentinoid. People are sniffing gabapentin and you abusing it in other ways. So it's hard to find a perfect solution when you're dealing with chronic pain issues. And don't forget the topicals. Lidocaine patches have efficacy. There are topical NSAIDs, which seem to work. Capsaicin works. And again, the hot and cold therapy might fit into topicals as well. And again, the overall point of the slide is that this is not the only way to treat pain. There are other dimensions that you can look at too, which have effectiveness and often will provide a better level of pain relief with less adverse effects. So chapter 3, which we just did, explain what pain is to people, the neurobiology of it. If they understand what's going on, they may do better with the problem, and explain how multidimensional the pain is. Now we're going to do, I think, our first polling question, and here it is. Your patient requests an early, so now this is skipping ahead and assuming that you are prescribing an opioid for a patient. Your patient requests an early refill for the second time in 6 months, took extra medication for a headache and again for a toothache. Prescription is for lower back pain. I think a polling question is going to come up now. I think we're going to see it on the screen shortly. Oh, okay. The question was, does this patient require further evaluation? Yes or no?
Those are the results, Dr. Solsitz, of the...
Should I say, I'm not seeing the results.
Okay. I'll send it in the chat for you from now on, but it's 95% yes, 5% no.
Okay, so yes is the right answer. It doesn't mean that anything awful necessarily is going on. I mean, you know, headache is painful too. Opioids are not first-line treatment. And definitely a toothache, I mean, opioids are sometimes prescribed. But this would at least require a discussion to see if everything else is kind of okay. Check the PDMP, maybe do a urine drug test, which we'll talk about. So it doesn't mean that you fire the patient, but it means that it's not a bad idea to discuss this with the patient and maybe set some parameters on how they're going to use the opioids. Okay. Oh, okay. Should have put that up right away. Again, not the end of the world, but an evaluation, a discussion with the patient might be a good idea. And we're going to come to something called a patient-provider agreement, which might have relevance to this question as well. Okay, now we're going to talk about how do you assess patients that are coming in with pain. So again, all of you who are providers, this is very, very basic history material. Where is the pain located? What is the intensity of the pain? The quality of the pain, is it sharp, is it burning? And of course, the more you know about different pain syndromes, the more this will help you. And the point of this assessment is to see if you can actually pin down a diagnosis of what is causing the pain. So, for example, the onset of the pain. Diabetic peripheral neuropathy pain is worse at night than it is during the day. Carpal tunnel pain is also worse at night. And so those kinds of clues might help you make a diagnosis. You know, when does the pain happen? How does it vary? What relieves the pain? Maybe some medications or maybe some physical activity or something else they might do to relieve the pain. What increases the pain? And again, I think this is going to be for many of us the most important box, and that is, what is the affective response to the pain? Are you able to function around the pain? Has it become a catastrophe in your life? So this is a very important box. And, you know, like what's happening right now with your function and your pain. Continuing along with this assessment, we want to get a history of what treatments they've used. So we want to talk about all of them. What have you done non-pharmacologically? Have you been to physical therapy? Did you do acupuncture? What about pharmacology? What drugs have you tried? What have you used? Are you using, what are you using now? You want to look at the state PDMP. We'll talk about that a little bit later to confirm what they tell you or to see what they're not telling you. And then if they're on opioids, you want to know how much they're on, which opioid they're on, and whether it's helping them or not. And you want to make a determination if they're opioid tolerant or not. And we'll talk about that in a moment, about why that's something that you want to do depending on the dose that they tell you they're taking of the medication. Now, one of the themes of the course, which is mentioned a number of times as we go through the course, is trying to evaluate whether somebody that you're thinking about prescribing an opioid to is at a high risk, an average risk, or a low risk of misusing the opioids. And so this slide starts to touch on that topic. But first it's saying that in terms of opioids, there may be some people who have underlying baseline problems that the opioids are going to make worse. So let's say somebody has significant CO2 retention from severe COPD. Opioids might make that worse by increasing the PCO2. If they have GI problems, opioids are likely to make that worse. If they have cognitive impairment, opioids can do that, particularly if they're elderly. And so you might say, you know what, I don't think opioids are the right medication. Although there are different opioids, and some of them would have less of an impact on some of these problems compared to others. Now, I don't agree with the hepatic renal disease because we face this with any medication we prescribe. If people have hepatic or renal impairment, we adjust the dose to account for metabolism and excretion issues. But I guess in some cases, maybe that would be a red flag not to prescribe opioids. Here's where they're getting into the risk for substance use. So hepatitis is a broad category. I guess hepatitis C, one of the main ways of acquiring it used to be IV drug use. Same thing for HIV, might be an issue. I think TB is not very common any longer. Now, when you talk about cellulitis, that's only with IV drug use. Most people, in terms of the prescription opioid epidemic, were not injecting their opioids. STD is too broad for me to be a risk factor for substance use, and the same thing with these three categories. They're just too broad. But I guess if somebody comes in and says, I had endocarditis 2 years ago, that might be a clue that they have been or are an IV drug user. More of the risk factor issue here, a little bit more reasonable, is what controlled medications are they on? Frequently, people are on a number of polysubstances. So, for example, benzos or stimulants that are being prescribed, that might be a clue that there's an underlying substance use disorder. Alcohol and tobacco. Anyone who's using tobacco regularly has a substance use disorder called tobacco substance use disorder. People who are addicted to tobacco have less of a response to the analgesic effect of opioids. You need more opioids to give them pain relief. In terms of alcohol, if the alcohol use is significant, then we have to look at that as a problem. Do they have an alcohol use disorder? They certainly have more injuries and more painful problems. And we don't want to combine opioids with excessive alcohol because they're both CNS depressants, and you can get a bad outcome. History of sexual abuse is very important in the addiction world. 80% of women who present for addiction treatment have a history of sexual abuse, sexual violence. So this is an important area to look at if you're thinking of prescribing opioids for anyone, females or males. Any family history of substance abuse or psychiatric disorders is a potential red flag. The vulnerability to addiction is at least 50% genetic or familial. And lower age group, the age group 16 to 45, these are people who don't get the most opioid analgesic prescriptions, but of the people who get opioid analgesic prescriptions, they are the ones who misuse and abuse them the most. So that age group carries the highest risk of misuse. And again, I've said this a number of times, and I'll keep saying it, I guess. This is where I think most of the money is most of the time. What is their life about? Are they happy? Are they unhappy? Do they have work that's satisfying? Do they have relationships that are satisfying? That's going to have a big impact on how they do with the opioids. So we're back to assessing the patient and examining them. So you want to get old information if you can, medical records if you can find them. You want to do a thorough pain evaluation. Now, depends on where you are in your medical career. Some people can do a really good one. Some people do just a moderate one. You want a general history and physical. You do the best neurologic exam you can do, musculoskeletal exam. So this is about straight leg racing and other maneuvers you can do to try to determine, does the patient have a disc problem? Do they have spinal stenosis? I've seen physiatrists describe this slide where they say they stand by the window in a suburban setting. They watch their potential patient get out of the car and walk to the office. And by the gait, G-A-I-T, by the gait of the patient, they can often tell what's wrong with them. If they're stooping over walking, they know they have spinal stenosis. So the better you are at this, the more likely you are to make a specific diagnosis. You want to look for skin changes or atrophy of muscles. In the diagnostic tests, there aren't really many of them that can help either with pain or with addiction. I think the general consensus is that we order way too many imaging studies for a usual presentation of acute back pain, that most of the time that doesn't need any imaging unless there's a red flag or it doesn't resolve in 6 to 8 weeks. There was a very important study done in the New England Journal of Medicine a number of years ago. 100 people, I think, asymptomatic, over the age of 55, all were given MRIs of their spine. In, I think, 50 to 60% of the cases, abnormalities like disc bulging were found, which, if the patient had had pain, would have been ascribed to the MRI finding, but the patients did not have pain. So I think the message of that study is that if you go fishing, you're going to find abnormalities, and you're not going to know if they're the cause of the pain or not. So in order to help you determine this risk problem or this risk issue, different tools have been developed over time. These are 3 tools that you use before you start somebody on an opioid to determine what their level of risk is. We'll talk about this one in a moment. These are tools that you use for ongoing prescribing. Are they running out early, checking the PDMP? Are they going to other providers to get medication? And these are just non-specific screening and brief intervention tools. Most of you probably know about the cage for alcohol. You can use it for drugs as well. Some of them are shorter, some of them are longer. Here's an example of the opioid risk tool. It's popular. One of the reasons it's popular, I think, is because it's relatively straightforward and easy. In some practices, they have some of these tools embedded into the EMR. So what is the opioid risk tool looking at? Any family history of substance use, any personal history, the high-risk age, 16 to 45, the sexual abuse, any psychological problem, depression, anxiety, doesn't matter. You fill the boxes in, you add them up. You got a low risk of 0 to 3, moderate and high, and then you say to yourself, okay, low-risk patient, I'm going to prescribe an opioid if it's indicated. Maybe I don't have to worry much about how often I'm going to monitor the patient. Boy, a high-risk patient, I still think opioids might help, but I will monitor this patient in a different way than I would a low-risk patient, give them less opioids, see them more frequently. Now, there have been a number of editorials saying that it is not the patients who carry the risk, it's the drugs themselves, that they're just risky, they're inherently risky, and that there is no way to stratify the risk, and that you're fooling yourself if you think you can. So I'm going to say this a number of times also, that I think each provider is going to have to look at all the evidence, put it together for themselves, and come to their own conclusions about how they want the information to impact what they do. This is looking at the other screening tool called the SOAP, Screener Opioid Assessment. I don't use this. It comes in a variety of different forms, shorter, longer. The patient can do it on his or her own. Someone else in the office besides you can also administer it. It can be done online. It's similar to the opioid risk tool. So those are the tools you can use. Now, this intersection, and this should say like chronic opioids, and this should say chronic non-cancer pain, and this should say addiction, they overlap. And in the space where they overlap, things get very, very complicated. And I'm often asked to see patients, let's say 4 months after a knee replacement, still taking opioids, whether they're addicted or whether it's just a pain problem that hasn't gone well. And it's not easy to tell sometimes if you're looking at a substance use disorder or you're looking at a pain case gone bad. It takes a lot of time teasing out the history, but very often what I find is it's actually a pain case gone bad, where opioids have been prescribed for too long, people have developed physical dependence, they want to be off of them, but they just have a hard time getting off, and every time they try, they develop withdrawal symptoms, they go back up, and very often that is interpreted by other providers as they're addicted to the opioids, which is not necessarily true. So as this whole opioid epidemic was developing with the analgesics, one of the questions that everybody wanted answered is, if I put 100 people on chronic opioids for chronic non-cancer pain, like back pain, knee pain, what % of those people will develop a substance use disorder. And believe it or not, it was very difficult to come up with a number. In the studies that were done, the numbers range from 0 to 50%, which tells you that nobody knew. But there was some very reputable studies done which came out with numbers like 3 to 5%, which seems very low, but that's what the data showed. And that was, of course, very encouraging that this is not going to be a big problem. But it turned out that those studies were flawed in many different ways, and that if you were asked the question today, the answer is that at least 30, maybe up to 50% of people on chronic opioids around the clock are going to develop something that could be called a substance use disorder. It's always going to be highest in the people with a past history of substance use disorder or psychiatric comorbidity, and so you have to really follow patients closely as they go on with the treatment. If you like this kind of acronym stuff, you got these 5 A's for pain. So when you see a pain patient, you're treating. How's the pain level? Or how's the analgesia? Many experts now think asking about pain 0 to 10 is useless, and that what you should only focus on is activities, function. How are you doing? Are you getting up off the couch? Are you back to work? Are you doing more family functions? Look for problematic behavior, which we'll talk about, adverse effects like constipation with opioids or cognitive impairment, and how are they feeling? Are they happy? Are they doing okay? Or are they depressed? With addiction, the key to addiction is loss of control, which in this area that we're talking about today would be taking more than prescribed, running out early, craving the drug, thinking about the drug all the time, and having problems from the drug, but still wanting to continue using the medication. So what about consider? We did the assessment, we have the patient, and now we say, well, he'd been on other medications, he failed non-opioids, non-pharmacotherapy, the pain is moderate to severe, which is a requirement for opioids. Should I or should I not try to put him on a trial of IR? The CDC recommends that all initiation of opioids be done with immediate release opioids. Should I or shouldn't I try an opioid? And here they're giving you opposite ends of the spectrum. They're giving you a 60-year-old man, he's got chronic disabling osteoarthritis. He tried the other therapies, the non-pharmacologic, non-opioid didn't work. He's got no risk factors in terms of the risk factors we've discussed. And you say to yourself, you know, maybe if I gave him 5 or 10 milligrams of an immediate release oxycodone, maybe he could take it PRN, not around the clock. Maybe it would help him meet his friends and have a cup of coffee or go to the mall or something like that. And so, you know, it might be a reasonable thing to try. On the other end, you have this 30-year-old woman with fibromyalgia. Opioids are not indicated for fibromyalgia. She's got an alcohol problem. So she would be a very high risk to put on opioid therapy for anything. It's not first line for fibromyalgia. Drugs like the gabapentinoids and duloxetine are. And so the slide is still saying that if everything else in the world has been tried and it's coming down to opioids that might work, you could do it, but you'd have to really monitor very, very closely because she's not really a good candidate. So we'll talk a little bit more later about the CDC guidelines. They came out in March of 2016. If you do any kind of pain work, you should have this available. Read them. There are 12 recommendations with lots of evidence for why they made the recommendations. Some people have some problems with some of them. I think overall it's pretty good. So here's some of the things they say. Always begin with an IR opioid. A number of years ago, many people were beginning with extended release opioids like long-acting OxyContin. Of course, you're going to prescribe the lowest effective dose with any medication you prescribe. And here they're saying there should be some dosage limitations that you're thinking of. And in all the guidelines, the dosages are calculated as morphine milligram equivalents. And we'll talk about how you figure that out later. But they're saying try not to even go over 50 morphine milligram equivalents a day. That's only 2 or 3 oxycodone pills, let's say 10 milligram pills. So that's not a lot. They recognize that you're going to have to go over 50 a lot of the times. So they say, okay, but don't go over 90. And by the way, there is very good data to show that there's a direct correlation between the dose of opioids that are being prescribed to people and the overdose death rate. And of course, it goes up linearly with the amount of opioids prescribed. So now for acute pain, they're saying prescribe the lowest amount that's needed. And each state now is coming up with their own guidelines. And I think we'll have information about that later. But for example, in New York, now by law, for acute pain, no more than 7 days. In other states, it's 5 days. From the ED in New York, if you go to the ED, no more than 3 days allowed by law. Reevaluate people frequently. Maybe they don't need the opioids anymore. And so those are some of the initial CDC guidelines. By the way, cancer pain, hospice, palliative care patients are not covered by the CDC guideline. And really, no one has much of a problem with prescribing chronic opioids for those conditions. The big issue comes in with chronic non-cancer pain. That's where the problem has come in. People recommend, although you don't have to, but it's recommended that you get an informed consent if you begin an opioid in somebody, if you initiate an opioid. Explain to them that the pain score is not going to go to 0. We want to improve function. These are the expectations. These are the risks, up to and including overdose death. Sharing with family members. You've got to be very careful and make sure that they understand that they should have tried the alternatives to opioids, and also that there are going to be adverse effects. Constipation remains common in 50% of people on opioids. We talked a lot about addiction and misuse already, but people should also know that if they stay on opioids, men are going to develop low testosterone in many cases. There's going to be something called opioid-induced hyperalgesia, where they're going to have, as they raise the dose of opioid, they're going to have more pain, not less pain. Women may have irregular menses. So what that slide is saying is that make sure people know that so that they don't turn around and say, the provider never told me my testosterone level was going to go down. Now, in addition to the informed consent, it is recommended to have a patient-prescriber agreement. And this is the kind of thing that you and the patient or you and somebody else in the office or in the clinic puts together, clarify the goals. It overlaps a little bit with the informed consent. Lots of education goes into the patient-provider agreement. Here you're going to discuss how I want you to store the medication, dispose of the medication. As I said before, these topics have become huge in the last year or two. And here's my responsibility, here's your responsibility. Here's more detail on what the patient-provider agreement could be about. One prescriber. So if I prescribe controlled medications to patients, I do want to be the only prescriber of controlled medications. I don't want people getting a benzo from somebody if I'm prescribing an opiate. I don't know about Consider One Pharmacy with e-prescribing. That may not be too important any longer. Again, this is coming up over and over again, and we'll talk specifically about that later. We'll talk about disposal later, too. Now, this is important as well. You need to tell people, I have you on an opioid, or I have you on a benzodiazepine, or I have you on a stimulant like amphetamine or methylphenidate. I will be doing random urine drug tests on you. You can do saliva, too. I'll use the word urine, though, for the matrix. I'll be doing random drug testing on you, not because I don't trust you, but because that's what I do in this office. People will say, don't you trust me, and push back and say, this is what we do. Tell them up front. And also you might say that if I need to, I might call you in and have to do a pill count and make sure that you have the right amount of pills. Some medications are refillable. You might want to talk about that with people. And you might say, look, if this happens, if I find that you're selling the medication, if I find that somehow or other you forged my prescription, then I'm going to have to discontinue the medication. I can't prescribe for you any longer if that happens. We want to continually monitor adherence to the medications, the controlled medications, and we're looking for, I like the term problematic rather than aberrant drug behavior. And how do we do that? Well, we use some of the only objective parameters that we have in the field of addiction and medicine, and that is we check the state PDMPs and we do urines. We want to make sure that the drug we're prescribing is in the urine, see if any illicit, illegal drugs are in there. We want to use family members and caregivers. They can be very important in terms of handling, storing medication, taking a part in the treatment. We talked about the monitoring tools, and we talked about pill counts. These are some examples of what are called problematic behaviors. Some of them may not really be very consequential. They took a little bit more from time to time. They said, hey, this helped me with sleep, so I'm taking it at night. Is that okay? They're getting it maybe from somebody else because you weren't around. These are not so good. Prescription forgery, selling the pills. So these aberrant problematic behaviors come with sort of less severe, more severe. And again, some people doubt that you can make that distinction. But what the main message is, that if you find problematic behavior, you don't reflexly say, I'm firing you from the practice. You say, hey, what's going on? Tell me about what's happening. Maybe I can help you. Maybe I can refer you to a higher level of care that would be more appropriate. Very easy to say in a webinar, document everything you're doing. It turns out to be important. We all know that. It's hard to do, but try hard, particularly with opioids. So I won't do the pearls for this. They're very, very obvious. Do a comprehensive H&P and document everything. I think now what we'll do is take a 10-minute break. And so we'll give you time to get something to eat or drink and use the bathroom facilities. And we'll reconvene, a little bit before or around 1:30. Hey, Jack, are you there? Jack?
Hey, Dr. Saltitz.
Hi. Everything okay on your end?
Yeah, everything's looking great on my end. Actually, I was about to tell you. So for the polling questions, I just realized it's not going to it's showing it on my screen now. It's not going to let you see the responses. I think what I'll do is when we do those, when we get to one of the polling questions, I'll come on and say, okay, the polls are open for the next 15 seconds. And then when I close it, I'll read off, because you still have the responses, right, with you?
Right, I have the responses.
So I'll read off the responses and the percentage of people who answered, and then I'll hop back off the line, and it'll be back on you.
Are the participants seeing the poll results visually?
Yes, they're seeing it visually.
Okay. Yeah. Okay. Let's. I got a little bit. Didn't go that well the first time because I was waiting for the thing to pop up.
Yeah,
okay,
it previously had, but it did not on this one, and I think it's because you currently have the PowerPoint in front of you, but I think it's still better that way. Okay.
Is it going along okay technically so far?
It's going along very well. Very well. People are asking questions. It's going on. We currently have a 207 on the line, so.
Wow. I'll tell you one thing, it's much more of a challenge doing it without looking at and hearing people in the audience, Not so easy. You know what I mean?
Yeah. I understand.
I can't tell what's going over, what's not going over well.
People seem very engaged in it. Definitely a good amount of people had questions on the opioid risk tool and the patient prescriber agreements when you were talking about that, and then also on some of the state information.
Okay. I usually don't like to talk too much about the patient prescriber agreements, so I wonder what they have questions about.
Well, I think often when they have questions, it's because they might be a little confused on it.
Okay. No problem. We take all questions.
Awesome. All right, thank you, Dr. Saltitz.
All right, so are we going to just be quiet now until about 1:30?
Yes, that works. I can mute you until exactly 1:30 if you want that.
And then what do I do? Do I just start up again and I got the slide on the screen and just get back into it, right?
Yep.
Should I start at 1:30 or a little bit before? What do you think?
It's
like
entirely up to you.
I have 1:20 right now. What do you have?
I have 1:20 as well.
Because initially we said that we'd go 10 minutes, so maybe I'll start like at 1:27 or 28.
That sounds good. I'll leave your audio on so you can just start speaking when you're ready.
Thanks a lot, Jack.
All right, no problem, Dr. Salsa.
All right, welcome back, everyone. I am cognizant of how difficult it is to sit before the screen and look at the slides and listen to a person speak and show so many slides over this length of time, but this is what we're doing today. I hope you were able to get a little bit of refreshment and relax and stretch a little bit. So here we go, and now we're moving on to management. So we've already evaluated the patient. We've done some sort of a risk assessment. We tried to get an informed consent, tried to use a patient-provider agreement, check the PDMP, and now the presumption is that the person is on an opioid, starting with an IR opioid, maybe has segued into an ER opioid, and now we're going to manage the patient and monitor the patient. So what are we monitoring? Well, we've discussed this a number of times already. Opioid side effects, they are a problem. Tolerance develops to many opioid side effects. So, for example, sedation, cognitive issues, respiratory depression. Generally speaking, tolerance develops to that. Tolerance does not develop that often to constipation, and so people may have ongoing constipation. In elderly people, falls and fractures are increased, particularly if they're combining opioids with benzos, which are very, very common. Some people report increased sweating. Meiosis, constricted pupils, is something that tolerance never develops to. It's an interesting factoid that people on opioids for 50 years still have constricted pupils. Some people have urinary retention initially that generally goes away. We talked about testosterone, and we talked about some of the other factors as well. What's interesting about opioids, sort of counterintuitive, is that even with this list of opioid side effects, they don't cause any specific organ damage. And let's say you compare that to tobacco, alcohol, cocaine, all of which cause organ damage in every organ in the body. But opioids, if you can avoid an overdose death, are not toxic in that sense. They don't cause liver damage, they don't cause renal damage, or brain damage for that matter. So emphasizing monitoring people for respiratory depression, we don't want that to happen. The greatest risk for respiratory depression is when you initiate therapy or if you increase the dose on someone. When you do that, that's when they might have a problem with respiratory depression. You know, the signs of that are decreased rate of breathing, decreased volume of breathing, becoming somnolent. In some cases, that looks to a patient's family like, hey, they're doing well, they're relaxing on the couch, they're sleeping, and meanwhile, they're actually overdosing, unbeknownst to the family. And if you think that anyone is having an overdose, you got to call 911. We'll talk about naloxone later on, having that available. Where is respiratory depression more likely to occur, or in whom? Elderly, cachectic, debilitated patients. Maybe they shouldn't be on opioids to begin with. If they use polysubstances like benzos, alcohol, and again, if somebody is opiate naive and you give them a high dose of an opioid or you increase it too much, you might get a problem with respiratory depression. How do you reduce the risk? Very, very simple mantra with opioids. Start low, go slow. Start low, go slow. You can never go wrong by doing that. We're going to talk about converting from one opioid to another in a moment. It's called opioid rotation. You have to be careful when you do that. We also don't want people tampering with the extended release products. We don't want them making an extended release into an immediate release. This is becoming less of an issue with more and more tamper-resistant formulations coming on board, but it still remains an issue. We don't want people cutting the fentanyl patches, and we don't want them in any way adulterating any of the long-acting capsules or tablets. Now, when do you go from an immediate release opioid to an extended release opioids, and why would you do that? Well, one reason you would do it is that if people are on a short-acting opioid like oxycodone, which has a half-life of 3 to 4 hours, and they're taking it around the clock, that means that every 3 hours or so, they're going to develop some withdrawal symptoms. At a certain point, they're not going to be able to tell if it's pain that they have or withdrawal. All they're going to know is that the signal is to take another oxycodone. So I'm going to say that, in my opinion, I don't think that around-the-clock immediate release opioids are going to work out for most patients. They're going to develop a problem with it because of the pharmacokinetics of the short-acting opioids. And so I think that anybody who's on immediate release opioids and they can't manage it as a as-needed PRN medication and take it regularly, consideration should be given, if you want to continue with opioids, to switching them to an extended release opioids. They're going to maintain a more stable level. They'll probably be able to sleep better throughout the night, and they won't have the peaks and the troughs and the signaling all day to take the immediate release opioid. Sometimes people just want to try something new. Insurance may be an issue, which is unfortunate, but it does happen. And sometimes there may be drug-drug interactions that may be better with a different formulation. Again, this is talking about the immediate release to the extended release. And what we want to understand is that the extended release opioids generally have significantly more of the molecule milligram-wise than the immediate release. So, for example, extended release oxycodone, 80 milligrams, has 80 milligrams of oxycodone. You're not going to get that amount in an immediate release product. So that's one of the dangers of early opioids, is that they contain more of the milligram of the opioids. We don't want to give most of these early opioids to people who are not yet opioid tolerant. And in any case, you cannot use any transdermal fentanyl or any hydromorphone extended release in someone who is not opioid tolerant. We're going to define opioid tolerant on the next slide. We also don't want to use the higher dosages of any of the early opioids in people who are not opioid tolerant. When we do put them on that early opioid, we want to monitor them closely initially. That's the danger period. And we want to tell them about the adverse effects. Again, that's the same thing we've talked about before. So here is the FDA's definition of what they consider to be someone who's opioid tolerant. Again, this is arbitrary. I don't think it's based on much evidence, but it would be this amount of whatever the molecule is for a week or longer. And if somebody has done that for a week or longer, then they are considered to be opioid tolerant, and then you could give them any of the extended release that you want to, even though you'd still have to be careful. But again, the two that you shouldn't use are fentanyl and hydromorphone if they're not opioid tolerant. Now we're going to talk very briefly about opioid rotation. In the heyday of opioid prescribing, this was a very common topic with lots of literature about the topic. And what this is about is that somebody was on, let's say, an extended release opioid. Let's say they were on oxycodone, and they were increasing their dose due to tolerance, lack of effectiveness, and you thought, as the provider, you know, maybe if I were to switch them to a different molecule like hydromorphone, I could get a better analgesic effect, I could be on a lower dose and have less adverse effects. And so the idea was to rotate them from one of the opioids to another one to try to get better outcomes and less adverse effects. And the underlying mechanism of why this would work is that we all have slightly different mu-opioid receptors. And since each one of these medications have different potencies and bind differently to each receptor, the idea is that some might provide a more favorable profile than the original one that the person was on. Okay, I know this is kind of confusing, but we'll get there. Back here for a minute. Now, in order to switch from one opioid to another, you have to have some idea of what the equianalgesic dose of the new opioid is going to be compared to the established opioid that the person is on. And in order to do that, what you need are equianalgesic dosing tables. They come in a variety of different versions and forms. One of the problems is they don't always have the drugs you're looking for, They're done only in an acute setting. They don't take into account age, gender, racial, other genetic differences. So they're very, they're not very fine-tuned, but they're what we have to work with. So here is an example of a typical equianalgesic dose table. Everything is usually compared to 30 milligrams of morphine. So in this particular table, it says that 20 milligrams of oxycodone equals 30 milligrams of morphine. In some tables, this is listed as 15, so that there's a 2-to-1 ratio. Here it says that hydrocodone is 30-30 equianalgesic, and other tables say this is 20, so there's a 3-to-2 ratio. In all tables, hydromorphone is the most potent oral opioid there is. The most potent opioid of everything we're talking about today is fentanyl, but that doesn't really come in an oral form, so hydromorphone is the most potent oral formulation. And what you would do is you would figure out what dose of these other opioids the person was on. You would convert that to the morphine milligram equivalent, and then you would figure out how much to give of the new opioid. And again, going back to the rationale for doing it, again, this is a cartoon showing different subcategories of mu-opioid receptors, and you can see that drug 1 has a bigger impact or activates these receptors more than the ones on the outside, whereas drug 2 doesn't activate them as much and activates the other ones. And so the idea is if you could find the right drug for the right person, you get a better response, lower dose, less adverse effects. This is kind of getting into the field of pharmacogenomics, which maybe one day we'll be able to tailor everybody's drug to their receptor status. Now, after you make the equianalgesic dose calculation and you figure out that X dose of hydromorphone is going to equal the dose of oxycodone that they're on, you have to account for something that's called incomplete cross-tolerance, which means that you may have overestimated how tolerant they're going to be to the new opioid. And so in order to correct for that overestimation, all you do is reduce the new opioid by 25 to 50% of whatever you calculated it to be. You're going to do a higher reduction in people who have more other medications on board, more concurrent medical problems, elderly, frail, and maybe only 25% in those who are healthier and the cases are not as complicated. And by doing that, you hope to eliminate the fact that you've gone above their opioid tolerance, you're not going to get any sedation, and you're not going to get an overdose. Methadone's on the next slide. You do not use equianalgesic dose tables to rotate onto methadone. Methadone is a very tricky drug to use. It's an excellent analgesic. It's very cheap. Some insurance companies sometimes will ask the provider to please use methadone instead of a more expensive formulation, although this is happening less and less. The general rule is that people think that you shouldn't start anybody on methadone who's not opioid tolerant, and you certainly shouldn't use methadone unless you're very familiar with its pharmacokinetics. The problem with methadone, it has a very variable half-life. It could be 20 hours, it could be 100 hours. The other problem with methadone is that most people think of methadone as once-a-day drug for methadone maintenance for addiction. And it's true that 24-hour dosing for addiction works in terms of suppressing withdrawal and craving. But when it comes to analgesia, methadone only has a 6 to 8 or 4 to 6 hours of efficacy. So the analgesic duration is not as long as the addiction duration. And what happens is that if people take more frequent doses of methadone for their analgesic effect, the respiratory depressant effect, which is longer acting, is accumulating and building up. And so the scenario is that somebody starts on methadone for pain, they take 5 milligrams, 10 milligrams, they still have pain, they take more. After a couple of days, they're still taking more. Then one day, they're lying on the couch, they're snoring very loudly. The family is very happy, they're not in pain, they're resting. 2 hours later, they're dead. And this is a very common occurrence with methadone coming out of the pain sector. You've got to be very careful, and you have to start low and go very slow with methadone. and wait 4 to 5 days before increasing doses to account for a steady state pharmacokinetics of the medication. So that's a lot about methadone. So you're never going to give more than 40 milligrams. This will be somebody who would be opioid tolerant, and somebody who's not and you wanted to use it, you would do something like 5 milligrams BID to begin with. And you'd have to let efficacy for pain be a secondary factor and safety be the primary factor. In terms of the patches, fentanyl and buprenorphine, they come with good product inserts that tell you how to switch over from an oral opioid to the patch product. This is a topic that I think is becoming less and less important because less and less opioids are being prescribed chronically for pain around the clock. But when this was all happening, the idea was that somebody was on chronic long-acting opioids. They were taking, let's say, 3 oxycodone long-acting, 40 milligrams a day, but yet they would have breakthrough pain. When they walked up the hill by their house, it would hurt, or when they went to physical therapy, it would hurt. They would have pain. And the idea was that you would give them an immediate release opioid, either the same molecule or a different one, and that when they anticipated the pain or had the pain, in addition to the long-acting, they would take the short-acting, and that was called breakthrough pain. What happened in my experience very often is that people just started taking the breakthrough pain immediate release opioid on a regular basis, every 4 hours, in addition to the long-acting. And so I don't think it worked out well most of the time, but that's the concept of breakthrough pain. If you do breakthrough pain management, it should really be sparingly and PRN. Once it gets to be regular around the clock, it doesn't really meet the definition of what breakthrough pain was supposed to be. There are lots of places where you can get help. SAMHSA, the Substance Abuse Mental Health Service Administration, has a lot of good information about substance problems, addiction problems, and also about mental health problems. Again, those are very, very common in chronic pain patients. And refer to pain folks and refer to addiction medicine specialists in the more difficult, complicated cases. We're going to move on and talk about urine drug testing. I'm just going to talk about urine today. You can substitute saliva most of the time if that's what you're doing or that's what you want to do. So what I would say to begin with is that if you're prescribing controlled substances, I think the standard of care in 2018 is that you do random, occasional urine drug tests. If you're not, I think that's a problem in anyone who's getting controlled substances from you, no matter what the indication is. Urine drug tests are done for the patient. It's an objective test that we have to see how they're doing and if we can help them along and help them with the problems that they have. We're looking for problematic behavior. We're looking for addiction problems. And we're looking to find out what is going on. Are they taking medication or not? How often you do them depends. There are some regulations, but it primarily is a clinical decision. The urine drug tests come 2 different ways. There's a screening test, which is the one that's done first, and that's called an immunoassay test generally. You can either do that by sending it out to a laboratory, or you can use dipsticks and do them in the office. That's called point of care. And you can get dipsticks that have, let's say, 11 or 12 different drugs on them, like oxycodone, buprenorphine, methadone, opiates, benzos, and you dip it in the urine, and you get a result in 2 or 3 minutes. Generally, it works well. There can be false positives, false negatives on the immunoassay, so they have accuracy issues. They also have certain screening cutoffs, and if you're below whatever the cutoff is, the drug might be there, but it's not going to produce a positive result because it went below the screening level. So, if you're doing urine drug tests, you can be doing these point of care or send out lab-based immunoassay screenings. You might want to also consider having a laboratory that can do confirmatory testing. That's done with a different technique called gas chromatography mass spectroscopy or liquid chromatography mass spectroscopy. These are always sent out. These are very expensive. Insurance often does cover them, though. And this is the kind of thing where if you're doing an immunoassay and you have benzos on your panel, you're going to get a positive, let's say, on a benzo. But then you're going to say to yourself, what is that? Is that the lorazepam I'm prescribing? Is that alprazolam that they're getting from somebody else or buying on the street? Is that diazepam, chlordiazepoxide? Unfortunately, clonazepam rarely, if ever, comes out positive on these immunoassays. That's one of the limitations. And the same thing would go if you get like amphetamine on there. Is that something they took for a cold? Because amphetamines are notorious for having false positives. Or is it an actual illicit amphetamine that they took? So by doing the confirmatory test, it tells you what exactly is causing the positive test in the immunoassay. How long do drugs stay in the urine generally? The answer is 1 to 3 days for most drugs. It depends what the dose is. It depends about metabolism, water intake. Some drugs that have high lipid solubility, if you use them regularly, like marijuana, they're going to be detectable for 30 days. Same thing with Valium. Again, this would be high dose regular use. Now, in addition to checking the urine for the drugs, the other thing you have to check the urine for is its integrity. Is it urine? Did somebody bring in their own urine? Is somebody substituting somebody else's urine? Did somebody bring in apple juice? Is the urine looking very, very dilute? Did somebody try to drink massive amounts of water before they came in, knowing that if they could make the urine dilute enough, even though the drug might be present, it will be below the screening cutoff of the test? And there are lots of online places you can go that specifically deal with how to beat a urine drug test. There's a huge literature out there and many different ways to do it. How do you get around that? Well, you can have a cup where you're doing the point of care testing that has a temperature strip. And so you want the temperature to be between 90 and 100 degrees Fahrenheit. You want the pH to be in this range. And there are strips, point of care strips, that measure pH, measure creatinine, measure specific gravity to help you determine whether this is a valid urine sample. You want creatinine to be generally above 20 milligrams per deciliter. If it's less than 2, it's not compatible with human urine. And again, it could be dilute because the person's trying to dilute it. So doing urine drug testing is very, very important. You do have to know about some of these issues. Generally, people do not substitute urine. Generally, give you the urine. It's very rare that anyone has to have an observed urine. It happens from time to time, but it's very uncommon. What does a urine test tell you? Let's say somebody pops up positive for cocaine. Well, all it tells you is that they used cocaine in the last couple of days. It doesn't tell you that they're addicted to cocaine. It doesn't say they have any physical dependence. It doesn't even tell you if they're impaired. All it tells you is it's there. So you have to understand that the urine test has certain limitations in terms of how you're going to interpret it. Now, if you have a negative result, somebody's on oxycodone, the urine is negative, to me that's a problem. Here they're saying it doesn't tell you for sure it's diversion, but something's wrong. Running out early, they couldn't get more of it, they haven't taken it for a few days. But I would say that not seeing the drug you're prescribing is usually troubling when you're looking at a drug result. Now, in addition to all of that we discussed, in relationship to the opioids themselves, the metabolism can be very confusing and interesting. We talked about morphine in the opium poppy plant. We said that it was converted to heroin by putting 2 acetyl groups on it. Very short half-life. You never get a positive for heroin. The intermediate product, short half-life. If you get this on a urine test, it's pathognomonic for heroin use. Nothing else is going to do that. Codeine, which is in the opium poppy, is a very weak analgesic. It becomes an analgesic when it's converted to morphine by cytochrome 2D6. If people are poor metabolizers of codeine, they will get no analgesic benefit from it. Now, here's the part that gets trickier, though. Codeine, some of it can be metabolized to hydrocodone. Some of that can go to hydromorphone. Oxycodone can go to oxymorphone. Although this happens in very small quantities and would only be picked up on the confirmatory tests. This would never be picked up on a screening test. But you'll see later when we have a little exam thing that they're going to make the point that you could find hydromorphone in the urine of somebody who's using morphine, where you might think, uh-oh, they're using something I didn't prescribe. They're using hydromorphone that they got from somebody else, where it could just be that it's the metabolite of the morphine. Red flag. Okay, you decide not to request routine urine risk assessment for fear of creating conflict. Mrs. Lane and the family have been your patients for years. She has chronic headache and back pain. She has been treated for chronic pain and back pain. When you ask, with an opioid, ask her to take a UDT, urine drug test, she becomes upset and accuses you of not trusting her. Fight against further risk assessments because you're concerned about damaging the relationship. You've known her for many, many years. So the polling question is, should you, and now these are multiple choice, pick the one that is best.
And the poll is now up. And they're able to select more than one answer here.
No, there's only one answer on this one, Jack.
Okay.
One answer on this one.
Alrighty, Dr. Saltitz. So for agree to delay UDT, 1% of respondents answered that. 8% of respondents said schedule UDT for next visit. 91% said require UDT as a universal precaution. And 4% said trust with patient is the most important.
All right. Well, most of you got the right answer. The right answer is require UDT as a universal precaution. And yeah, it's tough to do sometimes, but you got to say, look, this is the policy. These are controlled medications. There have been problems that you've read about with them. We're going to be doing random urine tests, and if need be, we might have to even do a pill count. But so 91% of you got the right answer, and that's really good. And we'll move along right now. Discontinuing opioids. Now, why would that happen if somebody's on chronic opioids? Well, maybe the pain really did get better, go away, and the patient recognizes it and says, I don't think I need to be on opioids. A lot of adverse effects. A lot of people discontinue because of this early in the treatment. They say, I'm not getting that much pain relief, and the adverse effects are too much for me. And this is a tough one where somebody's been with you on opioids for 5 years. The pain was a 10 when they started. It's still a 10. No functional improvement. And you got to say to them, look, not all pain syndromes are opioid responsive. We're not making any progress. And when we talked about aberrant behavior, I don't want to go through that again, but there might be some problematic behavior that rises to the level where you say, I'm sorry, I know you're diverting and selling the medicine. It's illegal. I'm not going to prescribe for you. You'd have to somehow arrange for them to go to someplace if they've been taking the pills or some of the pills and be detoxed, because you don't want to just leave them in opioid withdrawal. Now, when you decide you're going to withdraw somebody and taper them, how do you do it? So all I can tell you is that we can read every bullet on here, but there's no good evidence on this. There's no rate that you should do it. This has got to be very individualized. Each patient is different. Some people can taper off relatively rapidly. Other people have trouble with each milligram. And many people are very annoyed. They said, no one told me that this physical dependence would result in this kind of thing. But one thing you shouldn't do, you shouldn't mistake difficult physical dependence for addiction. Just because somebody can't get off does not mean they're addicted. It probably means they were kept on the medication for too long and didn't require the medication. And that's why people should be getting off of this medicine as soon as possible. I wanted to say one other thing here, and that is you might need to refer a person like this to an addiction medicine specialist who has familiarity with buprenorphine, because buprenorphine can help in this situation, and so can judicious use of methadone, where you switch people over and then taper them off either buprenorphine or methadone. But yeah, there's no good way to taper people off. Now, there was a recent study published where a group of people were on long-term opioid treatment for chronic pain, and they agreed to either reduce their dose significantly or to withdraw, to discontinue. And in those patients who wanted to do it and went along with the procedure, they all reported less pain and a better quality of life, either off opioids or with a dramatic reduction. And again, that's counterintuitive. But if people don't want to do it, then it's a real struggle, and I have no good answer for that, and neither does anybody else. So pros for this practice, we talked about everything here, so I won't reiterate it because we went over it. Now we have our next red flag here, which has to do with the urine drug test. And here the question is, Donald has been prescribed oxycodone for 6 months to treat back pain. His urine drug test at 6 months comes back negative in all areas. He tells you that he is taking his medications. So the question is, which of the following, the question is, what should you do? There are multiple answers. One of them is correct.
And the webinar is up, and the polling question is up. Alrighty, and the results are 5% said discharge patient, negative UDT means he's not taking meds. 51% said repeat UDT and document everything. Another 51% said confirm that your UDT can pick up oxycodone. And 29% said check PDMP.
You know, I was wrong. Jack was right that there were multiple answers that could be right. I'm sorry. I was wrong on that one. Although I do think that the most important choice is choice number 3, confirm that your UDT can pick up oxycodone. This is a very, very common mistake that's made where people have a UDT panel and it says opiates on it, OPIATES, or it says morphine. And many providers think that if they're taking oxycodone, hydrocodone, a semi-synthetic opioid, I'll be able to pick it up. They may or may not know that they'll never pick up methadone, fentanyl, or buprenorphine, the synthetic opioids. But oxycodone will not be picked up reliably unless you have a tab that specifically goes oxycodone. On the other hand, repeating it and documenting everything, that sounds right too. And checking the PDMP, I guess to make sure the patient's filling the prescription, could have also been the right answer. So everybody did very well, and I think I goofed a little bit on that one. Okay, sorry about that. Yeah, so yeah, we don't want people fired immediately. These urine drug tests have lots of false negatives, false positives, and we got to make sure that we're testing what we think we're testing. And there can be reasons that people are going to test, are not going to have the test you're looking for. So it's a way to talk to people about what's going on. Okay, moving on to special populations. Older people, elderly people. So as we know, with any drug category, as people age, pharmacokinetic changes occur, metabolism, excretion, less muscle, more fat, so distribution changes. Polypharmacy is common in older people. And we've talked about this, but we should emphasize that with opioids, with benzos, risks, cognitive change also occur. And so that's a very important consideration. So, you know, it's just logical. You all know this with all medications. We're going to start lower in debilitated people and monitor them more closely. Here's the start low, go slow saying. Now, patient caregiver, it's nice if you have a good, reliable caregiver, and you rely on the caregiver to take care of things. But there have been numerous reports of caregivers stealing medications from the patients they were supposed to be monitoring. Maybe older people have more constipation, so maybe a bowel regimen earlier.
Dr. Salsa?
Yeah.
Could you please press the share your screen button, the green share your screen button one time, and then press it one more time because it's not changing from the poll, and I think the webinar system is messing up. And then press it one more time. Okay, perfect. Thank you.
Okay, we're okay now?
Yes,
Should I go
Dr.
back?
Shelton.
Should I go back to any slides?
Yes, go back
to where I am.
Just go back, I think 2 more slides. Or go back to the end of the polling question and 1 past that.
Yeah, it's not going back, Jack. I can't make it go back.
Okay, that's fine. That's fine. Just keep going.
Okay, sorry about that. I don't know what was in there. I thought it was just special populations, and there was just a summary of something. But I was saying this is important, the falls and the cognitive decline, and caregivers have to be reliable, otherwise they steal the opioids. Wait a minute, I'm having technical problems here. Click to read your unread chat message. I'm having trouble advancing the slide now. Click this here for a minute. Go back here now. Maybe that'll do it. Yeah, sorry. So that was elderly people. Now we're moving on to women with childbearing potential. You might be surprised to know that 40% of women of childbearing potential in one recent CDC study were being prescribed opioids. Not known if they were taking them regularly or not, but they had prescriptions for opioids. There's a lot of data about pregnant women who are opioid addicted in pregnancy, about the safety and efficacy of using methadone and now buprenorphine in pregnancy. And that data has been around for 50 years with methadone and about 15 years now for buprenorphine. There's not much data about the other opioids that would be used chronically in pregnancy for pain. And so the caution is to, if at all feasible, don't use chronic opioids for pain in pregnant women. Because if you do, there are some reports of teratogenic effects of some of the opioids, not methadone or buprenorphine. You have to check women, do a pregnancy test, because some women might not know they're pregnant if you're starting opioids on them. And if women who are pregnant are going to be on opioids chronically, there's going to be a risk of developing the opioid withdrawal syndrome in the neonate. That risk is about 60 to 80%. It's the same with methadone and buprenorphine, but it's something that is expected and can be treated relatively easily. So again, we're back to the pregnant woman with chronic pain, not the pregnant woman who's addicted to opioids. Try not to use opioids. If you do, try to limit them, not make them regular. Definitely work with an OBGYN in addition to yourself. And again, if you had to use an opioid during pregnancy for pain, I would think that the 2 most logical ones to use, based on the most data available, would be either methadone or buprenorphine. And buprenorphine would probably be preferred because it has a better profile in terms of the neonatal abstinence syndrome. Okay, this is an easy category. Children, young adolescents, no real data on this category. If anyone had to be on chronic opioids at this age, you would think it would be a very serious, life-threatening problem, and you'd probably be working with a pediatric specialist or pediatric palliative care team. Just for your information, transdermal fentanyl is approved in children 2 and older, and oxycodone approved in people over the age of 11. But again, I don't think the average practitioner is going to prescribe continuing opioids to any young patients. Okay, here we have another one, a red flag question here. And in this case, there are multiple answers which can be correct. So your job is to choose all the ones that could be correct. 78-year-old Thelma comes into the clinic accompanied by her grandson, who was in the exam room with you and Thelma. Thelma says her oxycodone 10 milligrams every 4 hours. Let's put aside the fact that that's probably not a reasonable thing to do in a 78-year-old woman, is no longer working for her back pain. She asks for more medicine. You ask the grandson to leave the room so you can examine her privately. And the question is, which of the following is the right course of actions for this patient?
Alrighty, and the poll is now distributed. Alrighty, Dr. Salsitz. So 80% said ask Thelma if she stores medication in a locked container. 61% said ask Thelma if she has caregivers who work in her home. 77% said ask Thelma if she shares meds with relatives or friends. And 56% said ask Thelma if she has noticed changes in her grandson's behavior. And only 2% said none of the above.
Well, that's good. What I was looking for here is that, unfortunately, grandchildren and children of elderly patients, and by the way, elderly folks are the ones who get the most prescriptions for opioids and benzos, that for some grandchildren and some children, these elderly people are the source of their opioids and benzos and other drugs. They come with the person's not that cognizant of what's happening. They skim off a bunch, and they come back with them a month later. So yeah, the answers were all four of those. Each one of those four would be the correct answer. This happens. I've seen it happen in my own practice a number of times. It's unfortunate, but something that you have to keep in mind. Okay, know your federal and state laws. So in each jurisdiction you're in, you got to know what's going on. I think the federal laws are pretty, not much has happened here, but a lot has happened here, and we'll look at some of it in a moment. But I think the biggest thing that's happened in state laws is the limitation on the amount of opioids you can prescribe for acute pain. As I mentioned, in New York, it's 7 days. In other places, it's less, and more states are developing these rules. We'll talk about prescription monitoring programs now. All 50 states have them. I'm sure most of you know how they work. They vary to some extent in who can be on them and when you have to look up the patients. Bordering states are available in many of these PDMPs. So I can tell you that in New York State, everyone who prescribes has to be registered, and that anytime you prescribe a controlled substance of any kind, you have to look up the patient in real time while you're doing the prescribing. It's not voluntary. It has to be done in real time, and somehow or other that's being monitored. We have about 20 bordering states now, which is very helpful. I have patients in Connecticut or New Jersey, and I want to see how they're filling their prescriptions there. So I think that everyone would agree that there's a lot of benefit to these PDMPs. Again, something objective that we have to see if people are seeing multiple providers. How are they paying for their prescriptions? People paying with cash, that's a red flag. So let's go through the PDMPs. Washington, D.C., you have one, Schedule 2 to 5, most of them are like that. Dispensers are required, but before prescribing, there is no obligation to review. So I don't understand why have a PDMP if there's no obligation to review under any circumstances. A lot of people have access to it. You can authorize somebody to be delegated to do it. It's got to be uploaded relatively quickly. And you'll see that states vary here. It does not share data with other states, so D.C. doesn't give out its information. Now, some of this may be outdated, by the way. These things are redone every few months, but it's hard to keep up with everything. And here, you'll see some states will notify patients that their record has been accessed. That doesn't happen in New York, but some states do have that. This is Delaware now. Same thing, Schedule 2 to 5. There is an obligation to review under certain circumstances. So those of you in Delaware might understand what the certain circumstances are. This is the same with authorizing a delegate. This is the same. And patients will not be notified if their account has been accessed and does share data with other states. This is Maryland. You have a program, Schedule 2 to 4. Before prescribing, there is an obligation to review. I just don't get what the certain circumstances are. In New York, it's like any controlled medication, you must look them up. Now, this is something, I wish we were live so I could ask people from Maryland. Patients will be notified. Maybe somebody from Maryland can send a comment into the chat room. Have the patients told them that I got notified somehow that somebody looked at my PDMP? We don't have that in New York. That seems curious to me. Here's Pennsylvania. Same thing. Obligation to review under certain circumstances. Patients will be notified. And does share. I have Pennsylvania on New York City bordering, New York State bordering states PDMP. And this is Virginia. Everything's the same up here. Obligation to review under certain circumstances. Patients will be notified. If somebody from one of the states where they're notified could send a comment in, if that's actually happened, I'd love to know how that works. And this is...
Hey, Dr. Saltis?
Yeah.
All the comments we've gotten so far says that they've never had a patient say anything about it.
Yeah, okay. So again, we think that these state slides are accurate according to the data that we get from the state. So maybe it's all a mistake. I don't know. Maybe they just left out the word not. Here is West Virginia. Everything's the same here. Their obligation to review under certain circumstances, and same thing. Okay. Now we're going to a new issue, which is what about education and mandatory training of prescribers. And here's Washington, D.C., physician, physician assistant, advanced practice nurse, no education requirements, and these folks can prescribe these schedules, which is usually a good thing. Here is Delaware. You have education requirements for everybody. This is Maryland. Again, it's peculiar how things vary. They say no education requirements for anyone. Oh, they're giving the acute pain. I left some of that out. So this is what? This is Pennsylvania. Acute pain, 3-day supply. Here, this is a peculiar too. 2 hours for physicians, but none for PAs, and 4 hours for nurse practitioners. Maybe it's because PAs have to work under a physician, and so they don't require them to get their own level of education. This is what, Virginia, no restriction on acute pain, and everybody has to have training every 2 years. And this is West Virginia. Everybody has 3 hours of training every 2 years. In New York, it's 3 hours, and I think it's every 2 years or every 3 years. We just started this year, 2017, with mandatory training. Cannabis, what a complicated, difficult topic. If you're interested in the health effects of cannabis and the pain issue, there is a monograph which was published this year, 2017, by the National Academy of Sciences, Engineering and Medicine. National Academy of Science, Engineering and Medicine. Go on their website. You can download the entire PDF for free. You can also download individual chapters. The bottom line is that we don't have enough data yet. As you know, cannabis is still a Schedule 1 according to the DEA. That it says in here that there is evidence that cannabis or selective cannabinoids are effective. Now, I could have sworn it said for chronic neuropathic pain. Here it says chronic pain, but I think they said specifically neuropathic pain. More research is needed, and people worry that people smoking a lot of marijuana, particularly children, adolescents, pregnant women, may run into difficulties like substance use disorder. And again, I'm not trying to advocate one way or another. I'm just saying it's a very, very complicated, constantly moving target. You pick up a systematic review one day and says there's good evidence for PTSD and chronic pain, and the next day another review says there is no evidence for chronic pain and PTSD. So a little bit of a summary here of different things that come into play. Try to use evidence when there is evidence. Look for adverse effects, which some people have. I mean, it's well known now that young people who smoke regularly may lose some IQ points, don't do as well in school, and also those who are prone to maybe develop schizophrenia may develop psychosis earlier if they're regular users of marijuana. So document things, consider urine drug tests, although it's always complicated what to do if you get a positive urine test. Anyway, I'm gonna leave it here, recognizing this is a complicated topic. It's a moving target. I think the future is selective cannabinoids like cannabidiol, which is approved in some countries for certain indications. I think that's where we're headed for. Selective cannabinoids with evidence, with dosages that we could prescribe, etc. But now we're going to look at the status of marijuana in the different communities we're dealing with today. Washington, D.C., legal to prescribe medical marijuana, and you have recreational use in Washington, D.C. And again, I hope these are accurate. Delaware, legal to prescribe, not recreational use. Same thing in Maryland, medical marijuana, no recreational use. Pennsylvania, the same thing. Virginia, not legal, so no medical marijuana in Virginia, not legal for recreational use. And similarly in West Virginia, not legal for both medical marijuana and for recreational use. Okay, here we have one of our next to last polling questions. We have a 18-year-old with a recurrent wound in the antecubital fossa, secondary to intravenous injection. This is her third wound debridement, and she is in more pain than before. She tells you if she cannot get relief from you, she will go to the street for meds. The following is true concerning the course of action in treatment, and select all that apply.
Alrighty, and the poll is currently up.
Select all that apply.
Alrighty. So the results are for start and link patient to treatment for substance use disorder. They got 77% of respondents chose that one. 79% of respondents chose the second choice, which is try non-opioid pharmacotherapy for pain. The third choice, 45% said IR opioids for short duration, 3 to 7 days, if number 2 not effective. For the fourth choice, untreated pain will likely lead to relapse. 47% chose that answer, and 23% said okay to treat patients with opioid use disorder with analgesics.
Was that last one 23, Jack?
23%, yes.
Okay, well, let's see what it says here first. For the drug abuse history, proceed with caution, use extra safety measures. Patient may require admission to either hospital or treatment facility while managing pain. This history does not mean you should discharge or avoid treating the patient's pain. From my point of view, all 5 answers are correct. Answer number 1, with the start and link patient to treatment, there have been a number of publications now where people have set up paradigms where you come to the ED with an overdose or something like this, and you get started on buprenorphine in the ED, and then you get linked up to some continuing treatment. You always want to use non-opioid pharmacotherapy first for pain. I'm surprised 45% only endorse the IR opioids short duration. We want to make that a paradigm now, that for acute pain, we're going to use short duration, usually not more than 7 days, and then reevaluate after that. The fourth choice, untreated pain will likely lead to relapse. That's definitely true. If you look at if you listen to many people out there who are opioid addicted, many of them will tell you that the reason they continue to use opioids is they have pain and they can't get any adequate pain treatment. So it definitely will lead to relapse. You've got to treat both of them at the same time. And the last one, which only 23% picked, it's definitely okay to treat somebody with an opioid use disorder with opioids if you're treating their pain, and that's what they require. You know, you're going to be careful about it. You're going to monitor it closely, but it's perfectly okay, legal, and legitimate to do that. Okay, that was interesting. Moving on to the next section now, counseling patients. There's this document called the counseling document, which I haven't used, but there are links to where you can download it, where you can specifically say to the caregiver, I want you to do X, Y, and Z, and the patient do X, Y, and Z, and that kind of thing. So I haven't used it, but some people might find it helpful. Counsel patients about proper use. Now we're getting into some repetitions, so I won't repeat things if we've done them already. You want to take everything as prescribed. Now these medications come with a medication guide each time you get them, and they have some good information, so that's something that a patient can read and inform themselves about. Let me know all the other medications you're taking. The falls we did already. Now, on this operating heavy machinery and driving, this pertains to when somebody initiates an opioid or when somebody's dose is changed. When somebody is stable on an opioid and they've developed tolerance to the sedating effect, they should be able to perform any occupation or function that they're otherwise trained to do. This includes long-term patients on methadone maintenance who are doing well. There should be no restrictions on their occupational ability. Yeah, you need to tell people that even though you might be doing it for good reason, sharing or even selling an opioid is a felony according to the DEA. And we talked a number of times about respiratory depression. We talked about, the ups and downs of caregivers. Keep it locked. We're going to reevaluate you from time to time. Please be careful around children, pets, visitors. We talked about not tampering with these medications, and the point is we don't want to make an extended release into an immediate release where all of a sudden the patient gets a huge amount of the opioid that they're not tolerant to. Some of these capsules can be opened and sprinkled on applesauce. This we haven't talked about specifically. Somebody's on a long-acting opioid, they take it, they have a glass of wine with their dinner. That's not a good thing to do in close approximation to the opioid, because somehow the alcohol can disrupt the extended release nature of the, let's say, capsule and release all the morphine, let's say, and that's called dose dumping, where the alcohol converts an extended release to an immediate release. And again, you can't say this too often. Try to avoid the combination of benzos and opiates. Overdose poisoning, we've talked about what that looks like. I think all of you know about that. I would say that loud snoring is really a warning sign because opiates exacerbate obstructive sleep apnea. Opioids also can lead to central sleep apnea. So some people have recommended that patients to be started on opioids should have a sleep study, particularly if you think they fit the description of somebody who might have obstructive sleep apnea. Naloxone. I think it's fair to say that in 2017, 2018, that any patient getting a prescription for naloxone should also be told by the provider, getting a prescription for opioids should also be told by the provider about how they can access naloxone. Some providers have naloxone kits in their offices given to them by departments of health. Others are going to tell people to go to a drugstore where there's usually a standing order and people can get a variety of different formulations of naloxone. That Narcan nasal spray seems to me to be a simple one to advise people to get. It also has, I think, a higher level of naloxone in it, 4 milligrams, rather than some of the other formulations, which are 2 milligrams. This is becoming important because of the fentanyl problem with the high potency of the fentanyl. So I think anybody on opioids should know about naloxone, should have access to it. Not only the patient, but also the significant others who would be the ones injecting or giving the person the naloxone should they overdose. So this requires a little bit of time and training where you have to tell significant others how to do this. Okay, I think that covers most of what's on the slide. By the way, there were some issues that people thought that maybe if people had naloxone, they would use more opioids and use them in a more dangerous way because one person wouldn't and would have the naloxone ready. But that's been debunked. Wherever naloxone's present, there's less drug use than more drug use. Here's naloxone regulations. Washington, D.C. Now, I don't know. This is supposed to mean Good Samaritan laws. I think this means that, let's say somebody overdoses with heroin, and the police are called, and there are needles and syringes around there, that if you have a Good Samaritan law, in which case these would all be yes, no one would be arrested, and nobody would fear calling the police. But I don't know if this is true or not. In Washington, D.C., they're saying that the interpretation I have here is that somebody could be arrested in calling the authorities, the first responders, because there might be illegal material at the scene. There's no standing order for naloxone, yet it says it's available without a prescription. So I don't know how that could be if somebody didn't leave a standing order. So I'm confused on that one. Delaware says lay people do not have the Good Samaritan laws, but prescribers and dispensers do. There is a standing order, so it's available without a prescription. In Maryland, again, lay people don't have the Good Samaritan law. I'm surprised about that because Maryland's been very progressive and has initiated a lot of the public health initiatives that are very commonly used everywhere today. There's a standing order. It's available without a prescription. Pennsylvania, Good Samaritan law all around. Everything is yes, yes. Same Virginia. I don't know if this is true, but it says no. And yes, it's available without a prescription. Some people, by the way, think that naloxone should not require a prescription, should be over the counter. And I don't see the argument against it, since giving someone naloxone who hasn't taken an opioid will not do anything. It'll be just like taking a placebo. West Virginia is yes all around. That's good because, as I've said, they're the state most impacted by the opioid epidemic. Okay, moving on to abuse deterrent formulations of tamper-resistant. This comes in a number of different ways. The tablet can be coated in a way that it can't be crushed, it can't be cut into. The capsule can be made so that the granules, if you crush them, will release naltrexone, so you'll develop a withdrawal syndrome rather than the opioid effect. Any new opioid that's approved now by the FDA must have abuse deterrent formulation. They won't approve them anymore if they don't. And this really was a big problem because before oxycodone long-acting became tamper-resistant in 2010, you could take an 80 milligram long-acting oxycodone, crush the 80 milligrams up, and now you would have 80 milligrams of short-acting, immediate-release oxycodone, which was very potent. And that was often called hillbilly heroin. People used to sniff that and inject it. You can't do that anymore with the oxycodone. Now, the problem with the abuse deterrent is the following, that in one study that was done, about 50% of physicians believed that because it was abuse deterrent, there was no possibility of overdosing or becoming addicted. And of course, that can't be true because the most common way that people overdosed on prescription opioids was taking them by mouth as directed. So you can't get into that issue, the overdose, and you can become addicted easily. The other thing about them is that they're all branded. They're much more expensive than generics right now, and so it's hard to get some of these through the prior authorization process. I don't think we have good evidence yet as to how effective this whole initiative has been with the abuse deterrent. What we do have evidence of is that in 2010, when oxycodone became abuse deterrent, there was a dramatic decrease in the use of OxyContin and the prescribing of it, but there was a mirror image increase in heroin use. And when people were asked, what are you using now that you're not using oxycodone, they said heroin. This slide's supposed to say that parents don't talk to their teenagers enough about prescription medications. They talk to them all about alcohol, marijuana, not enough about this, and that it is a big problem among teenagers getting their hands on these controlled medications. Here's another issue that has become an important issue, and that is disposing of opioids. The DEA has these take-back days. You'd have to look on the DEA website, see when they're coming to your area. You bring your medications and just dump them into a receptacle. But this doesn't happen often enough to really work out. In some places, the police department will take it back, or pharmacies will. There are often reports about how from the police department, they get stolen by the police and get sold, or something else happens to them. So most people are going to wind up doing one of the two things I'm going to describe now. Either take out the pills and put them in a plastic container like this, put in something like coffee grounds or cat litter, mush the whole thing up, seal it up, and throw it out in the trash. Take the bottle that it came in, deface the label, and throw that out in the trash too. That's very reasonable, and that's what the DEA says is a good way to do it. The other way to do it is to just dump it down the toilet. The pills, the only way you can safely get rid of a fentanyl patch is to fold it up on itself and throw it down the toilet. There's a lot of fentanyl left in the fentanyl patch after 72 hours. Numerous reports of children dying, rolling over on a patch like that, and cases of dogs dying as well. So flushing it down the toilet, it may not sound environmentally or ecologically nice, but it works, and it's a good way to do it, and it's probably the easiest way to do it. So pearls for practice, safe storage or disposal. The word medicine cabinet is an anachronism. You can't store medicine in a medicine cabinet in the bathroom. You've got to have it somehow secured, locked in a box, and put someplace else. Here we have our last red flag about safety, about storage and disposal. Your patient's daughter stole her father's opioids from his bedside drawer to take to a fishbowl party. A fishbowl party means that a bunch of teenagers get together. Each one of them brings whatever medications and drugs they can find in their home, and they each dump it into one of these large glass bowls called a fishbowl. Sometimes these parties are called a pharma party, P-H-A-R-M-A. Her best friend consumed them, and they put their hands in, they grab a bunch of these pills, and they take them. They have no idea what they're taking. Her best friend consumed a mix of opioids and alcohol and died of an overdose. So the polling question is, which of the following are true concerning opioid prescribing? And you pick the ones that are best. You pick the ones that are the right answers. There can be more than one.
So the poll is being distributed right now. Alrighty, and the results, let's take into account that, they were only able to answer one question on this one, but for the first one, 15% naloxone should be available when prescribed to patients only. 52% said naloxone should be available to those close to the patient. 34% said central nervous depressants to be avoided when prescribing opioids, and 0% said medications may be stored in a medicine cabinet in bathroom.
Okay, well, what percent was naloxone should also be available to those close to the patient?
52% said close to the patient. And then 15% said patient only.
Yeah. See, the problem with patient only is that patient, when they overdose, won't be able to take it. And that's why you need the significant others to know about what might happen, and if they look like they're overdosing, give them the naloxone. Again, it's time-consuming to train people, but if you train the patient might be able to train his or her significant others. By the way, there have been any number of patients who have given naloxone to other patients and revived them. Yeah, okay, good. So on most of the poll questions, everybody did very well. Let's see, we're in the home stretch now. This last section has a lot of summary information. I will only mention what we haven't said before. Some of these opioids, like tramadol and tapentadol, are serotonergic reuptake inhibitors, and if given with MAOIs, may result in a serotonin syndrome. So that's tramadol and tapentadol. Everything else we've sort of talked about, and so I won't go through it again. I'm anxious to leave enough time for questions. This now is focusing only on the transdermal patches, either buprenorphine or fentanyl. If somebody likes to sit in a hot tub every day, these patches are not for them. When somebody either sits in a hot tub or becomes febrile, in other words, temperature goes up, more medication comes through the from the patch through the skin into the blood, and that can cause an overdose. So patients cannot sit in hot tubs if they're wearing the patches. We did most of this stuff already, so I'm not going to do this. You can look at it if you want to on your own. This just says to me that if you're going to prescribe an opioid, like you prescribe anything else, you need to know everything about its dosing, drug-drug interactions, etc. I don't see anything really special here in terms of proper prescribing as opposed to anything else you would prescribe. Now, this was a systematic review, and the systematic review for the NIH was focusing on the effectiveness and risks of long-term opioid therapy for chronic pain. So again, this is chronic non-cancer pain, the effectiveness and risks. And what this showed is that evidence is insufficient to determine the effectiveness of long-term opioid therapy for improving chronic pain and function. Evidence supports a dose-dependent risk for serious harms. There has never been a study lasting longer than 3 months, a randomized controlled trial of chronic opioid therapy for chronic non-cancer pain. And as I said earlier, each provider will have to decide how they want to put all of this together. You can't read this. These are the CDC guidelines. They have 12 recommendations. If you do this kind of work, you need to get this. These are some of the highlights. We've already talked about them. Start with non-opioid, non-pharmacologic, realistic goals, do urines, check the PDMP, short duration for acute pain, etc. If you're have the kind of practice where you want to have a lot of information stuff for patients, you can get a lot of material about the CDC chronic pain guideline on their website. Okay, so we're going to stop here with what we've been doing. We're going to do one more thing before we get to your questions. Now, you're not going to be able to take this knowledge test right now, but I wanted to run through it as an educational activity, and then when you take it, you'll be able to, know what the right answer is, because we want people to get a good score, but we want them to know why the right answers are the right answers. So in that spirit, on question number 1, which is asking about the risk factor in terms of age groups, many times I've said this group has the highest risk, B, although they don't get the most prescriptions, these two groups get the most prescriptions. So the answer to the first question is B. Question number 2, if you're starting an extended release long-acting opioid, what's the most important thing to consider? A urine test won't help you. Patient preference is very bad. If patient says, I only want this one opioid, that's supposed to be a red flag. Cost of the medications could be an answer in the days we live in, but the answer is assessment of individual goals. Each patient's different, their risk is different, so the goal is the thing. A 55-year-old man being treated for chronic low back pain after undergoing laminectomy comes in for an evaluation. Trial of oxycodone ER is planned. Completion of which of the following is the most appropriate before initiation of therapy. The first two are disability indices, which are not going to help you in terms of prescribing the oxycodone. MRI of the spine, we said don't do. Blood tests won't help. You want to get the patient-prescriber agreement. This is what we're going to do. I'll have urine drug testing. We're going to do it for a certain amount of time and reevaluate you. Number 4, here's a 64-year-old lady, has a history of spinal stenosis. She's got peripheral neuropathy because of her chemotherapy for breast cancer, has had increasingly severe back pain. She reports the pain started 2 weeks ago after doing yard work. Underwent chemotherapy 12 years ago. Medications include an opioid. Which of the following is the most appropriate next step? And the answer is to reevaluate her underlying condition, because this is not a routine case. This is somebody with a history of breast cancer, has back pain, that could be, unfortunately, a late recurrence to the bone of breast cancer. So you wouldn't do any of these other things before you ruled that problem out. This is a red flag case of back pain. Number 5, use of oral opioids, pediatric patients. So this is really easy. The safety and effectiveness has not been established mostly for this population. Here's a 59-year-old woman. She's got hypertension. She's got kidney disease. She's got rheumatoid arthritis. She's on one of the new biologics for that. She's doing okay, but she still has a lot of osteoarthritis pain. It's inhibiting her from doing much of anything. She wants to be more functional. So what could you do for her? Well, Tylenol, acetaminophen, in many studies is no better than placebo. Duloxetine, she doesn't have depression that it says here. She doesn't have neuropathic pain. We certainly don't want to put her on 45 milligrams of morphine right out of the gate. And NSAIDs in her are a little bit dicey. She's got kidney disease. She's got hypertension. I don't think that would be a good choice. But if she could take some oxycodone, PRN, and maybe get moving a little bit, go meet her friends, that could work out for her. Number 7, inappropriate method to get rid of medication, dispose of it in the regular trash. Everything else is okay. I don't know if it's true or not. People say there are dumpster divers. People go through garbage pails looking for medication, seeing what people are throwing out. Most important reason you shouldn't tamper with a long-acting opioid is you may die, because all of a sudden you got this high immediate release coming in that you're not tolerant to. Number 9, when you're on an extended release opioid, what do you want to avoid? You want to avoid another CNS depressant. Alcohol is the only CNS depressant. You certainly want to avoid methamphetamine, but the correct answer is alcohol. I mentioned this about methadone. Which of the following extended release opioids is most likely to induce a peak respiratory depression that occurs later, persists longer than the analgesic effect? The answer is methadone. This is why methadone causes death. People take too much initially. They overcome their tolerance, and they die of a respiratory death. This is an easy one. We talked about when you do opioid rotation. How do you account for the incomplete cross-tolerance so you don't overdose people? You reduce by 25 to 50%. 12, we have somebody who's on immediate release around-the-clock opioids. He's having trouble. He wants to increase his dose of the immediate release. He says, what else can I do? And you say, well, maybe I'll put you on extended release opioid because you'll get more consistent plasma concentrations. It won't necessarily get fewer adverse effects or less respiratory depression, but you might get better plasma concentrations, so you take less pills, hopefully sleep through the night. 67-year-old female with osteoarthritis, converted from an immediate to an extended release opioid, has COPD. What else can you do besides give her the extended release opioid? And the answer is what we said before. Make sure she knows about naloxone and how to use it, and train people who would give it to her. And this is that trick urine question I talked about. Somebody's having a positive result for hydromorphone, patients on morphine, and nothing terrible is going on. It was a metabolite of morphine. Okay, so that's the knowledge test that we give at the end of the course. Whenever you do it, those are the reasons the answers are the right answers. And now I'm ready for Jack to give me some questions.
Hi, Dr. Salsitz. So if anyone wants to submit any questions right now for Dr. Salsitz, we'll be going through the chat box and we'll be adding them as they come in. So the first question I have for you, Dr. Salsitz, is from Beth, and she asks, do you need to enter into PDMP when prescribing to patients in hospice?
The answer is I don't know. If they're in the hospice, I guess, they're not going to be getting other medications. I don't know the answer to that. You're going to have to check with either your state authority or the hospice authorities. I would think maybe not, but I don't know the answer.
Alrighty. And the second question I have for you is from Talia, and she asked, how do you deal with patients' drug-seeking behavior?
Well, that's a very, very complicated question because we're not going to be able to do it justice in this format. If you believe that somebody is drug seeking and you believe that they don't require or need the medication that they're seeking and that it wouldn't be appropriate to prescribe it, I think you just have to tell them that I think that this would be a mistake. I'm looking out for your best interest. And I think that the medication you're requesting is something that I'm not comfortable prescribing, and so I'm not going to be able to help you. And maybe you can figure out what the underlying issues are and give them some alternative treatment, or maybe refer them to some sort of non-pharmacologic psychosocial treatment if that's what you think is going on. But that's a very difficult, complicated question to deal with in this format.
All righty. Dr. Salsitz, Tracy asks, you mentioned the pill count by physicians. How often is this done, and can you describe the procedure?
Yeah. I usually go into more detail when I do the pill count. I didn't know about the time factor, so I sort of let it go. I'm glad you asked the question. The word pill count, or the term pill count, is used in two different ways. One way that people use it is that I write a prescription for somebody on January 1st for an opioid, and let's say they're going to come back on January 30th for the refill. No, I'm sorry. Let's say they're going to come back on January 28th to get the next one. And I say to them, when you come back, bring the bottle and bring any pills you have left. And so maybe they'll have like 2 or 3 days left if they took everything correctly. So that's one way people mean pill count. But the way I really meant it here is that you're prescribing a controlled substance for someone, controlled medication, and for some reason, and it has to be a very good reason, you've become suspicious that things are not going well, that they're selling the medication, that they're sharing it, that they're diverting it, that really something significantly bad is happening, something real problematic. In that case, you would prescribe the medication on January 1st, and then you would call them on January 15th out of the blue and say, I need you to come in within 24 hours, bring the original bottle from the pharmacy, bring the pills that are in there, and then when they come in, you're also going to do an unexpected random urine drug test on them. So I hope that that clarifies what I meant by pill counts. I would only do the second procedure that I talked about, calling them that way, if I really had become suspicious. I wouldn't do that unless there was something that I thought was going on, because the patients are going to be insulted. It's going to mean you don't trust them. It's going to be difficult for them to get away sometimes. So I hope that that clarifies it. I hope that you find that to be a reasonable explanation or definition.
All right, the next question is from Kristen, and it's, could you clarify if women who are already on buprenorphine or methadone who then become pregnant should be advised to continue these meds or not?
I don't know if we're going to be able to go back and ask Kristen if these are women who are pregnant. I mean, if these are women who are getting their buprenorphine and methadone for pain or for addiction. I'm going to assume that maybe, well, let me not assume. Let me say that if women are on, was the question that they're already on methadone or buprenorphine, Jack, and they're pregnant, or they become pregnant?
Yes, and then they become pregnant.
Well, I would say that if there were a good reason for them to be on it beforehand, that they should be continued on the methadone. On the buprenorphine, I don't want to get into the weeds on buprenorphine, but it comes usually in a combination with naloxone or not in a combination with naloxone. And for pregnancy, we use not the combination, just the buprenorphine alone without the naloxone. In all other cases, we use the combination. So the answer is, if they're on the buprenorphine and methadone for addiction and they become pregnant, yeah, they definitely stay on it. If they're on it for pain, which I don't think is going to be very common, but they required it, then they would stay on it too, I guess.
All right, Eric asks, with the new saliva swab testing for drug testing, would it be used to discontinue care for a non-compliant / drug abusing patient?
Well, I tried to sort of talk about that a few times in a few different places. Any problematic behavior, a drug test that's not right, whether it's saliva or urine, or for that matter, a hair, HAIR, hair test can be done. Any PDMP problem, any other problematic behavior that you find is an occasion for you to sort of, digest everything you've discovered and sit with the patient and say, look, this is what I'm seeing. Can you help me understand why this saliva drug test I did on you today doesn't show the oxycodone that you're taking, shows cocaine, which wasn't present before. How am I supposed to understand all of this? And what do you think we should do? You don't necessarily fire people. We'd like that to be the last option. You might have to refer them to a higher level of care, or you might have to get some consultations. You might have to pull back on your prescribing. I like to verify things with significant others. It helps me if significant others can verify what the patients say. So that's how I think I would answer the question that you've asked. And I don't mean to ever make it sound like these are easy decisions to come to and easy work to do. This is difficult work, and it's time-consuming as well.
Hi, Dr. Salsitz. I'm going to ask one more question before we wrap up here. So this one's from Nisha. It says, could you repeat why adding acetaminophen was not the right answer for an elderly person with uncontrolled joint pain from rheumatoid arthritis? Is it liver toxicity? No, I wasn't looking for liver toxicity.
I mean, it could be the right answer. There are some people who do get a lot of efficacy or some efficacy from acetaminophen. I've been really impressed by a number of meta-analyses and systematic reviews lately for osteoarthritis showing minimal to no difference between acetaminophen taken orally and placebo. So on that question, we wanted to say that she's got severe pain from her rheumatoid arthritis, severe pain from her osteoarthritis, and that maybe something like oxycodone taken PRN could have a significant effect and help her, get out of the house and meet somebody. But certainly she probably tried acetaminophen on her own. Most people have tried acetaminophen and NSAIDs before they ever get to an opioid.
Well, I'd like to thank you so much, Dr. Salsitz, for presenting this course. Right now, I'm going to introduce Robert McKenna to close out the webinar.
Hi again, everyone. I echo the thank you to you, Dr. Salsitz, and to ASAM and to the ATTC and all of you participating today. That was a lot of really helpful information and strategy discussed for sure. If anyone does have more in-depth learning needs related to today's topic, clearly there was a lot that we didn't have time to cover today. Please do consider contacting ATAM or an ATTC in your area. Web links to both of those are shown here in the room, or will be momentarily. In fact, the Central East Addiction Technology Transfer Center knows the Mid-Atlantic states focused on during this webinar very well. So if you have questions about some of that state-specific stuff that was brought up during today's webinar, you can definitely contact that ATTC, Tamara, and you'll either know she'll either know the answer or at least point in the right direction for an answer. That said, please remember that information about continuing education credit applications is available in the handouts section. ASAM will be sending you a follow-up email reminding you of that related process and asking for your general feedback. And also, as Tamara described in the beginning of the webinar, the ATTC will send a certificate of attendance to everyone who doesn't request continuing education so that all of you have something in your records. And thank you again for your interest and your participation, and I hope you all have a great remainder of your day.